All right. Well, it's 9:10. Thank you everybody for joining us today for this conference. We changing course in real time with Intro to Career Launch, and we were unable to do the point of care ultrasound, and many of you had requested some education about the coronavirus pandemic, and I couldn't agree more. I know that some of you have had some education already. I've been tuning into some of the town halls, and I know some of you were able to join grand rounds. So some of this will be repetitive, although in calling through the material, I think much of what we're going to cover today should be novel from the educational materials that I have seen. And, you know, as many of you know, I've been helping to lead the coronavirus efforts for UCSF Medical Center. And I've also been reflecting on our duties as educators, and I think it is, probable that we will have future pandemics, and you all will be on the front lines. And so I think it is our duty to make sure that we prepare you and educate you and set you up for success. And so hopefully the next time this comes around, we can do even better than we've done this time around. So thank you all so much for tuning in. I have the group chat open. So what we will do is we will try to get through the slides for each one of our segments, and I will keep an eye on the chat and then try to make sure we address as many of your questions as possible. So here's today's agenda. Gonna have a 10-minute introduction right now. We're going to have Dr. Natasha Spottiswoode, who's joined us, one of our incredible medicine residents, teach us about the SARS coronavirus 2, as well as the outbreak. We have Dr. Sriram Shamasunder and Phuc Le, who are going to talk to us about inequity of pandemics and lessons from global health. We'll take a break. Then we will hear from George Rutherford about the epidemiology of this outbreak, as well as pandemics and flattening the curve. I'll take another break. This is a 5-minute break. We wanted to save as much time as we can for the last hour, because I'm sure there will be a lot of rich discussion. We have Dr. Srisha Narayana, who's going to talk to us about ethical considerations of the pandemic. And then finally, we have Drs. Sajan Patel and Francisco Alvarez, who were actually our first 2 physicians at UCSF to manage patients with coronavirus. And so they do not have any slides. They just were going to sort of speak from their hearts, and then also field any questions that you all have. Just take a moment to reflect on the importance of compassion and empathy in a time of global crisis. Much of the world is currently paralyzed by what is happening. And so I just want to take a moment to reflect on the importance of kindness, compassion, and care for ourselves and for those around us. It's an opportunity for those of us who have been running on full cylinders, and I recognize we are all in different positions at the moment. Some of us have been largely at home. Some of us have been in the hospital, managing sort of frenetically patients who are coming and going from the hospital. Some of us have been trying to care for our loved ones and significant others and other family members. And so just taking a moment to slow down, breathe, and pause, because it feels like things are moving at an incredibly fast pace around us. And sometimes slowing down is one of the most important things we can do to gather ourselves and make sure that we sort of are acting and functioning and thinking in the most productive, most effective way possible. Self-care means different things for different people. With the shelter in place, it is still okay to get out and exercise. So for those of you who like to exercise, please do. For those of you like me who meditate, now is a good time to do so. Some of you may have seen that Headspace is offering a free prescription. It's an app for mindfulness that is offering a free prescription to healthcare providers. And so I signed up for my free subscription last night. So please take advantage of this and other opportunities that I'm sure are coming your way. And for some of you, self-care might mean other things. I also want to recognize that times of crisis can really aggravate our anxieties, our mental health issues that exist at baseline. And so please, please, please take advantage of all of the resources available to you internally and externally. This is from the Medical Student Wellbeing webpage of all the different opportunities that exist here. Please don't suffer in silence. Please, if this is understandably getting to you, provoking anxiety, provoking depression, other concerns, please make sure that you are doing whatever you can to make sure that you are taking care of yourself. In my leadership role, I've been reflecting a lot on the cortical and the limbic aspects of this outbreak and of leading in this outbreak. And so a lot of what I've addressed so far is how to manage the limbic aspects, the anxieties, the fears that we have, the fears for our patients, our concerns for our patients, for those around us, for our loved ones, and for ourselves. And of course, there are the cortical aspects of confronting a disease, confronting an epidemic or a pandemic. And so this conference will be to tackle both of these. We will be talking about the clinical manifestations of coronavirus based on the clinical signs, symptoms, presentation, data, laboratory findings, and imaging associated with coronavirus. We will also be talking about the epidemiology of a pandemic and how to address that on a public health level. This is also a reminder that for those of you who are going to be on the ward soon, taking care of patients, not everything you see is coronavirus. This seems to be understandably pervading our psyches, pervading the news, and it's also pervading conversation in the hospital. But the rest, sort of the world goes on, and patients have other diagnoses and other challenges and other issues. So we have to continually remind our folks in the hospital to keep other diagnoses sort of on the forefront of our minds. I think I feel like my greatest obligation to you and is to really communicate the importance of your own safety, both in the community and on the wards. And so clearly a lot has been sort of discussed about social distancing. And so I think most of us are familiar with that, and we will learn more throughout this conference. Probably the single most important slide of this entire presentation is right here, is recognizing the importance of hand hygiene, which is really the most effective way that we can stay safe. For those of you who need assistance ensuring that you are washing your hands for a long enough amount of time, please feel free to check out washyourlyrics.com, where you can put in a song title and a song artist, and it will populate a poster for you to wash your hands to a song. So here is my chosen song yesterday, Lose Yourself by Eminem. And I'll spare you rapping through this, but I want to offer a disclaimer that Wash Your Lyrics does not recognize the sort of lyrics to every single song. For example, I subsequently tried to put in Gangnam Style by Psy, and I was less effective at generating lyrics for that. So just a disclaimer that that not every song will be recognized by washyourlyrics.com. In the hospital, the probably next most important thing you can do is learning how to don and doff, and making sure, for those of you who end up in a room for a patient with an aerosol generating procedure. Again, right now, students are not directly involved with the care of these patients, although there have been cases nationally of coronavirus that were not identified on admission. So it is possible that a patient gets admitted for a CHF exacerbation or a diarrheal illness who subsequently gets diagnosed with coronavirus. So ensuring appropriate use of personal protective equipment is critical. And the highest risk time period is when we doff, when we remove the equipment. So before you get on the wards, there are videos to review, and we'll make sure that all those are available. There are in-person training opportunities for those of you who are interested. And in the medicine residency, right now what we are doing is a video review followed by a quiz to ensure that all of our trainees sign off on their PPE training. And so please familiarize yourself with the appropriate. I just got a notification that I'm signed out, but it looks like I am still in. Can somebody confirm that I'm still logged in here?
You're good, Brad. We can still hear you.
Great, thank you. I just got a notification I got signed out. Sorry about that. So importance of appropriate donning and doffing of PPE is absolutely critical for your safety. There's been a lot written about how do I stay safe at home? How do I not infect my roommates or my loved ones in home? Our infectious disease group actually put out some recommendations that if you are appropriately donning and doffing, you will not be placing your roommates or family at higher risk by coming home. That said, a lot of our providers, a lot of our trainees are not comfortable bringing their clothes into their house. And so we are making scrubs available for those people on the front lines. The gym at Millbury Union is opening up hours for showering for those of you who want to shower at the end of the day before you go home. Again, these measures are not deemed necessary by our infectious disease experts, but they bring sort of comfort and security to many of us. I know I have a garbage bag that I keep in my garage, and this is probably TMI, but I do doff my clothing into a garbage bag in my garage, and I wash my hands before coming into the house. Just to see some questions here, where can we get the PPE videos? We will make those available to all of you after this conference. And another question, how are PPE being reused and what are the procedures being used to reduce the risk of that practice? Thank you for asking. We will also make that information available to you. Of note, these sorts of guidelines internally are changing almost on a weekly basis. And so the reuse guidelines today may differ when you are on the wards, but I'll be sure to make all of these materials available to you on Ilios at the end of this conference, recognizing that when it's time for you to come on the wards, you may need to sort of recheck this information, and we are including all of the medical students on the front lines with our sort of frontline provider dissemination of information. But please keep the questions coming. Finally, just to reflect on the fact that sort of recognizing that there's always suffering in the world, and nothing I'm going to say should downplay that. And this is a moment in time, nonetheless, where we are all sort of in this together. A time where I think unity is critical. It is heartbreaking beyond hearing the stories from China, Iran, Italy, New York, and elsewhere, where hospital systems are becoming overwhelmed. Doctors are having to make decisions about who can and who cannot receive life-saving, life-prolonging interventions. On top of that, to hear stories of discrimination is just absolutely devastating. And so now is a moment for us to come together locally and globally to really care for one another and to sort of pull each other through this global crisis that we are all dealing with together. And so I know that I'm sort of preaching to the choir, if you will, that you are, as UCSF medical students, on the front lines here, and you inspire me all the time. I just grabbed these headlines, and Peter Chin Hong has been sharing some of these with me as well. Just want to thank you, UCSF medical students. I did see Dean Lucy's note yesterday as well about the video that was made for our infectious disease colleagues. and all of the work that you have done to secure PPE. I know that there's been efforts to offer childcare for our frontline physicians, and so many other initiatives that you have mobilized and pulled together as part of this effort. I'm reminded as I watch the news of the people stocking the grocery stores at 2 o'clock in the morning, and all of the unsung heroes who are sort of keeping this country going, keeping the world going, and caring for sort of humanity as we all confront this together. On this thread, this video was shared with me, shared with me by a friend of mine in Washington, D.C. About 3 days ago. He was walking down the street in Washington, D.C., and he took this video. It's just about a minute, and I'll just share this because it's, I think, an important moment for me to reflect on community and what community means. Oh, okay. Sounds like you couldn't hear the video. I don't know why that didn't work, but I will try to get that working by the end of this presentation today so that you can appreciate it. Essentially, this apartment building spontaneously sang "Lean on Me," and everyone was participating. So I apologize you couldn't hear that. I'll see if I can get this video working to conclude the conference today. So I am following the chat feed. We have about, let's see. Oh, okay. 9:10 to 9:20. 9:30. So I've already eaten into Natasha's time, so I'll move forward. I'll keep an eye on the chat feed, and then at the end of Dr. Spottiswood's presentation, we will address your questions. So, Tash, are you there?
Yes, I am here. Can everyone hear me?
Yes.
Cool. All right. Can everyone see the slides?
Yes.
Great. Can I share my slides?
Oh, I can advance for you, unless.
Okay, that's fine. Cool. So everybody, my name is Natasha Spottiswood. I'm an R2 in internal medicine in the molecular track. My aim is to give you a brief overview of COVID-19, talk through everything briefly. Brad, could you give me the next slide? My disclaimers are here. Basically, as you know, this is a fast-moving topic. I am on service at the general emergency room right now, and so I acknowledge that some of this may be out of date by the time you hear it. I'm also not an expert in the area. Here is my email. If you have any questions, also feel free to put them in the chat, and I'll try and answer as we go. Next slide, please, Brad. So first of all, what is COVID-19? So just to introduce it, in December of 2019, cluster of pneumonia cases were noted in people who had been exposed to the Wuhan seafood market. Brad, click please. They did a BAL, which is to say a mini bronchoscopy into those people's lungs, sequenced what came out through Illumina, and what they found was a novel coronavirus. Now, I think that every micro talk should have a mugshot of the person who did it, so this is it. An enveloped RNA beta coronavirus. It's called a coronavirus because under electron microscopy, the spikes look like a crown. The fact that it's RNA is relevant in that it mutates quickly and is more apt to jump species. Next, please. And this is its family tree. So it's related to the common coronaviruses that cause upper respiratory tract infections. There are about 4 of them that are endemic in the human population and cause essentially the common cold. There are also 2 zoonotic diseases in that population. The blue at the top is SARS coronavirus, which, as you know, was an outbreak in 2002 to 2003. The blue near the bottom is Middle Eastern Respiratory Syndrome, or MERS, which has been causing smaller outbreaks in the last few years. And in red is the current outbreak of what's called SARS coronavirus 2019. So that's sort of its family tree. Next slide, please. So our next question is, where did it come from? And if we could just click through. So I would say a lot of these new viruses that affect humans, we think circulate in bats. That is to say, bats are the reservoir host. And there's a lot of really interesting theorizing about why bats. It's where Ebola seems to have its reservoir. It's where a lot of the new hemorrhagic fevers seem to. It's where like Henipavirus, it seems to be. And a lot of these viruses seem to have to pass through another animal before they get transmitted to humans. So in the case of SARS, we think it's civets, which is a kind of sort of weasel-like animal. In the case of MERS, or Middle Eastern Respiratory Syndrome, it seems to be camels. And then click, please, Brad. In the case of this new virus, we're really not sure what it is, but probably some animal that was being sold in Wuhan. Next, please. And then, of course, the danger with all of these spillover events, or zoonoses, is that they then have sustained human-human transmission. This is probably where the 4 coronaviruses that affect us now originated. And it's always the danger with a spillover is that it takes off in the human host and becomes an epidemic, or in this case, a pandemic. Next, please. So just talking through the first few months of infection, the first few cases were reported in December, and for a while there was not a lot of human-human transmission. It seems to be the case that whatever was the source in the markets repeatedly infected several people at a time. So there were these few reported cases of atypical pneumonia, which kind of went under the radar in that there were a lot of things that look like this. And then you can see around January is where human-human transmission chains really started to take off, and obviously created this very dramatic presentation that we have now. Next, please. So when we talk about epidemics, we really care about 2 questions. One, next, please, how rapidly does it spread? And then, next, please, how sick does it make people? So when we talk about each of these, we kind of have a critical number that we look at. So for spreading, it's R0, which is also depicted R0. For how sick it makes people, I want to use 2 different concepts, which are the severity pyramid and the case fatality ratio. And my aim here is really to give you the vocabulary to talk about both, because they're both used and kind of misused in the popular media. Next slide, please. So starting with R0, it's a concept called the basic reproduction number. And what it actually means is in a completely non-immune population, how many cases come from a single infectious case? And it's affected both by the characteristics of the disease and the characteristics of the population. Next, please. And next, please. So I like to use this diagram, which is actually just from a statistics blog. But if the R0 is 0, the disease will die out and decline. So from the point of view of the rabies virus, rabies is transmitted animal to human, but not human to human. So it has an R0 of 0. So from the point of view of the virus, humans are a dead-end host. It doesn't get spread within the human community. For a disease to be stable in the population, R0 should be around 1. So for every sick person, 1 person is infected. And if the R0 is 2, that's a recipe for exponential growth. So for every person who is sick, an average of 2 people get infected. And it's important to say that this is both a characteristic of the bug and of us. For example, measles is horrendously transmissible. In a completely non-immune population, you can have an R0 of 20, but we don't actually see that because we do vaccination, because we put people with measles on airborne precautions, because of the things we do. It doesn't have an R0 of 20. Next, please. So what is the R0 of COVID-19? Based on studies right now, next please, it seems to be around 2.2. If you're going to read one article on this, I recommend this op-ed by Dr. Fauci. It's a really good summary of what we know. But right now, the R0 is about 2.2, which is to say that it is spreading at an exponential rate. Next, please. And you can take the next slide. The next concept I like to use is the disease pyramid. And this is a way of thinking about any disease. It causes a different set of manifestations, from inapparent or clinically undetectable disease to a moderate set of disease burden to severe disease to death. And of course, some of those people at each level require hospitalization. So we can think about this both as the transmissibility of disease being at all these levels, and the burden that the healthcare system must meet being at primarily the higher levels. Brad, please. So I would say that the burden of this disease is what the hospital system has to cope with in particular, whereas the transmissibility, as we'll talk about in the next slide, may span all the way from the very severe cases to the very mild or pre-symptomatic cases. Next, please. So this is one of the biggest studies out there, and it's important to say that this is not yet peer-reviewed data, but just fresh data from the Chinese Center for Disease Control. They took about 72,000 patients, of whom 46,000 had PCR-proven COVID, and the others were diagnosed based on clinical judgment. And of them, they found that roughly 20% required hospitalization. Brad, next please. About 20% required hospitalization, of whom 5% were critically ill, as defined by respiratory failure, shock, or organ dysfunction. 14% had severe disease, as defined by difficulty breathing, and saturations less than 92%, ARDS and lung infiltrates, and about 80% were mild or moderate. So next, please. I would say that what I take from this data, and accepting that it's preliminary data, is that around 20% of people who are infected require hospital-level care. I see a question on how asymptomatic works. I will get to that in 1 second. Presenting signs and symptoms, this is one of the biggest studies which has actually looked at PCR-proven coronavirus. Next, please. So common symptoms on presentation include cough, fever, and the asterisk is because they used a lower temperature threshold to count as a fever than we do. We use 100.4, they used a lower number. So for us, it's even lower, it's more like 21%. And sputum production, myalgia, sore throat, and malaise. So I will say that I work right now in the emergency room at the General, and the trouble with these symptoms is that they're incredibly nonspecific. It is winter, kind of everyone has a fever and a dry cough. And we'll talk about how that makes this really difficult to diagnose. Next, please. Things that are rare include nasal congestion and any kind of GI symptoms. And then in terms of lab and imaging values, a lot of people have lymphopenia, or low levels of lymphocytes, as opposed to a high white blood cell count. And then CT scans show this quite unusual characteristic pattern. They tend to show bilateral infiltrates, what are called GGOs, or ground glass opacities. And they tend to be in a peripheral distribution, as opposed to a lot of diseases where they're more central. So really what I would point out here is that these symptoms are neither sensitive nor specific. Most people may not have fever on arrival. They may not even have a cough. And just to point out that these symptoms can be such a range of things. They could be rhinovirus, influenza. As Brad pointed out, we have non-infectious disease. This can be seen in COPD exacerbations and congestive heart failure. So it is very, very hard to tell what is most suspicious for COVID versus all these other conditions. Next, please. So focusing on some groups of special interest, we care a lot about healthcare workers because we are them. This was 3.6% of that first case study coming out of Wuhan. And it's worth pointing out that over 60% of infected cases in China that they reported were infected in Wuhan, which is to say during the first outbreak when no one really knew what this was or how to protect from it. So they probably were not wearing the same PPE that we now take as normal. There were 5 deaths, and it's worth mentioning that most of them they think were infected via family clusters and not at work, although they didn't print the data. Pregnant women, also an important group. There's been a few small case studies, and essentially there's not much evidence of worse outcome, minimal evidence of vertical mother-to-child transmission. But it is worth saying that, next please, it's also worth saying that We have no data on first or second trimester infection outcomes because this has not been around long enough. Both SARS and MERS are associated with miscarriage and other bad outcomes, but they behave clinically in such a different way to this virus. It's very hard to know what to take from that. Children seem to be doing remarkably well. There are very few cases in children, and those that are tend to be mild, and we would really like to know why. So imagine I have a sign saying more data needed, and I just hold it up at intervals, but certainly more data needed. Next, please. And then another thing we'd love to know is, once people have recovered, are they immune? How long do they shed virus? So there's one small study showing that people still have PCR detected virus up to 14 days after recovery. But it's important to say that PCR detection of virus does not equal infectious. So we also just need a lot more data on that. And then talking about non-severe infections and asymptomatic transmission. So this is really at the bottom part of that pyramid. So there's a paper here I really love. Next, please. Sorry, can you bring that up, Brad? Anyway, I'm going to keep talking about it, and the slide hopefully will advance. Basically, there was a paper coming out of a German group where they evacuated about 126 people from Wuhan and then tested them all for the virus. Oh, thank you. Okay. Looks as though we've quit out there. Anyway, so basically 126 German citizens were evacuated from Wuhan. They then looked at all of them. 10 of them had respiratory symptoms, so fevers, chills, myalgias, and they isolated those people. They sort of sent out the other 116 who were asymptomatic. And of the 10 who were isolated, they were all negative. Of the 116 who were released, 2 of them were positive. And I think this really nicely illustrates why this is a hard problem, and why the symptoms are so non-specific and non-sensitive, and not sensitive either. In terms of how it is being transmitted, so respiratory droplets from coughing and sneezing is probably a mechanism. And I think that I see Alexander has asked a great question about efficiency of transmission from asymptomatic patients. And again, I'm going to have to hold up my imaginary sign and say more data is needed because we are not sure how it's most commonly transmitted. It probably can be via several routes, but we haven't got the kind of household studies we need to understand how it's being transmitted in those circumstances. It's a great question. I think we'd like to know. And when I see Amy's question about how few children get the virus, I think that is also, her question is, are they less likely to get infected or less likely to have symptoms? I think there are some studies now showing that children do get symptoms, but they are much milder. And I think at first they were sort of being lost in the general like miasma of childhood respiratory infections. So I don't think they're silent vectors. I think they're slightly sick vectors. Does that make sense? The false positive rate of the tests. I think that because the PCR tests the tests are at the moment PCRs, there's very few false positives. So I think most tests being positive is true infection, but it is possible to be asymptomatic and infected. Let's move on because I want to make sure we get through the next slide. Brad, can you take us to the next slide? Thank you so much. Next slide. I will get to Austin's question in just a tick. So this is talking about the sickest patient. The sickest patient. So this is one of the first ICU studies to come out of Wuhan. So they took 52 patients who were admitted to the ICU care in Wuhan. There was a mortality rate of 61%. And the clinical presentation is essentially bad ARDS, so diffuse lung damage, plus minus other organ dysfunction, liver, kidneys, and heart. Predictors of death in the ICU were age, chronic medical conditions, worse ARDS, and the need for a ventilator, which all makes sense. Next, please.
Sorry, I'm just having, my computer keeps freezing. 1 second.
No problem. I can also show it from mine if that would be helpful.
Okay.
And your own. So this is talking about the case fatality ratio. And it's important to say this gets thrown around in the media a lot. And the case fatality ratio can mean many different things. So you can say, of the people who get the virus, how many pass away? You can say of the people who get the virus who require hospitalization, how many pass away? You could say how many pass away who require admission to the ICU. And what I'm trying to say is these are all really different questions. The case fatality ratio, if you define it as deaths over undiagnosed cases, I will make sure that the slides get out somehow. If you consider that we're missing a lot of minimally symptomatic or asymptomatic cases, the denominator is likely much, much larger. So while there are some reports of a case fatality rate of around 4%, I think that's pretty unlikely. We now think it's around 1 to 2%. I see that we're having a little, I ask your forgiveness for the technical difficulties. Let me see if I can, can we get onto the, so essentially this is just a way of looking at that mathematically and just saying that since we don't know the denominator, we don't really know the true CFR. But we're finding out as we're testing more widely, and ratcheting things down. And it's also important to say that this is also something we control. While like we control R0 through our own actions and through social distancing, we also control the case fatality ratio. This number is higher when medical systems are overwhelmed because people are not as able to provide care. So this is also something which we can affect. Next slide, please. And there's also a bunch of age variation. So for patients over 80, as has been reported, the death rate is more like 15 to 20%, whereas 20/40 is less than 0.5%. To Austin's question, severe infection presentation in younger patients, I do not know of anything showing pre-existing respiratory condition in those patients. It's important to say that there are a lot of young people. And every flu season, we do in the hospital see young people with no respiratory conditions, no conditions at all, who are critically ill. Less than 0.5% is still a lot of people. And so I think it's fair to say that it can make people who are young and have no conditions quite sick. This is looking at the CFR. The Lipsitch et al. Paper cited below is literally a paper on why estimating the case fatality ratio early in an outbreak is super hard. In part because in the first few phases of an outbreak, so early in this graph here, we're only catching the most severe cases, like the tip of the iceberg. And as it goes on, we get a better idea of what asymptomatic or minimally symptomatic infections look like, and the CFR decreases. Cool. Basically, it's a hard problem. Next, please. I wanted to show how COVID-19 sort of stacks up against a board of pathogens. So rabies is at the top, which kills around 100% of people, with one exception of a patient in Milwaukee. Ebola, depending on the outbreak, it kills around 25 to 80% of patients. MERS, which is the coronavirus relative that goes through camels, is about a third. SARS is about a tenth. And 1918 influenza is 1 to 2%. Rachel is asking what we can do in the hospital to help prevent death from COVID-19. A lot, and we're going to talk about that in just a sec. Seasonal flu is about 0.1%, and click please, Brad. COVID-19 is somewhere in the middle. We think it's somewhere between seasonal flu, which is itself very serious and causes our hospitals to be more full in the winter than the rest of the time, and 1918 flu. Next, please. How we test patients. Right now, Brad, you can just bring up the slide. Everything that we've been doing is based on PCR, so they should be fairly sensitive and fairly specific, but we don't have numbers on that yet. And I know there have been problems with some of the tests that were rolled out. And obviously, we would like a point of care test, and I think some people today are going to talk about that. This is very much a rapidly evolving space. We also right now don't have serologic tests, so we can't tell if there's an IgM or IgG response if someone has recovered yet. Next, please. Let's talk about antivirals. So this is a space where definitely more data is needed. One more click, please, Brad. And I would say that the TLDR is that more data is needed. Basically anyone who can work on this is working on this. So HIV protease inhibitors are being tried. That's the lopinavir-ritonavir. That trial is published in the New England Journal and essentially had negative data. It didn't seem to work for the primary outcomes. Chloroquine and hydroxychloroquine are both being trialed. Chloroquine is an old malaria medication. Hydroxychloroquine is a derivative that we use to treat autoimmune diseases. And so we're trying to figure out if those work. So far, it's hard to tell because the second study is very small, and the first study is not yet peer-reviewed. And as frustrating as peer review is, it does matter. So I think we just have not got the data yet, but very exciting space to watch. Other things that are being tried include remdesivir, which is a broad-spectrum antiviral. The idea of survivor's serum, which was used in the Ebola outbreak. All of these are being trialed. Next, please. And a big question is, when do we get a vaccine? The short answer here is that it's fast to take drugs that we have and repurpose them. Making a vaccine has a lot of steps in it, which are very, very hard to speed up. So I think it is fair to say about a year, even though everyone is moving as fast as they possibly can. I think this is going to be a year. Next, please. Public health measures. So just talking through some terms. Next, please. This, of course, is the Diamond Princess, which is sort of a emblem of difficulty with public health measures. 4 terms I want to define for you: isolation, quarantine, contact tracing, and social distancing. It's important to say that isolation is not the same as quarantine, although in the States they're often used interchangeably. Isolation is taking someone who is known to be sick and separating them. Quarantine is taking people who are at risk for being sick and separating them. It's interesting to look into the legal basis of quarantine, which I did for about an hour and then got so confused I had to stop. One of the things that is hard about public health in the United States is that it's not run by the country or the states, it's run often on the county level. So in practice, that means that San Francisco could decide to enforce quarantine and pay the people who had to stay home, and Marin could make a totally different decision. So all this to say, it's a confusing patchwork of laws that govern our quarantine response. Contact tracing is how we stopped SARS and how we stopped Ebola in the States. The idea is you find one sick person, track down all of their contacts, and then quarantine all of their contacts. It's something which has worked very well, but is hard to scale up when this virus is getting so prevalent. And that's where we come up with the idea of social distancing. The idea behind social distancing, as I'm sure you all know, is that if you have 2 people who interact, there is a non-zero chance that one of them has coronavirus and can pass it on to the other one. So by decreasing the total number of human-human interactions, you slow down the spread of the virus. Next, please. And this brings us to the idea of bending the curve, which is now very much in the public domain. This is one of the Vox Media images. And so the idea is we have some hard limits on our medical system. We have a set number of beds, a set number of ventilators, and we want to avoid reaching those hard limits. We want to give everyone the best possible care that we can. So in order to avoid overloading the medical system, we have to flatten that curve, make it a slower epidemic instead of a huge fast one, which overwhelms our capacity. And so we're really finding out what the limits are on our ability to provide care and how we can avoid reaching them. Next, please. In terms of the American spread, as you all know, the virus was first described in the States in someone in Seattle, and since then has spread rapidly. And let's get to the next slide, please. I also think it's really important when talking about this to sort of acknowledge the prejudice that has come with it and has been a part of the discussion. Allyship is more important than ever. And I also, not because firstly it's important, but also because I think as UCSF doctors know, stigma and prejudice are no way to combat an epidemic. Next, please. In terms of looking forward, I would recommend both of these editorials. The next, please, because I think they do a really good job of talking through not only what this means now, but what it means for the future. Especially the Bill Gates one points out that pandemics are becoming more common, or epidemics and spillovers. I have not been a doctor for very long, but in the time that I've been in training and been in medicine, we've seen Ebola, Zika, SARS, MERS. As the world becomes more global, this is going to keep happening. And so we not only need to treat the patients in front of us, but find a way to better respond to the next epidemic. We need to have a better way to surge hospital capacity, have a better vaccine pipeline, repurpose drugs rapidly. And I think we can learn a lot from what's happening. And I look forward to working with all of you on it. I have some acknowledgements, I think, for over time. Please feel free to email me with any questions, and thank you all so much for your attention.
So, Dr. Spottiswoode, this is extraordinary. I asked Natasha to speak to you all today because she is a leader within the residency program. While this was new and everybody was unclear of how bad this was going to get and what was happening, Natasha spontaneously organized a conference and educated all of her peers about COVID-19. So really just an incredible display of the power of advocacy and of what a resident can do in residency. And she quickly became a coronavirus expert among her peers. And so, Tash, thank you so much for taking the time to do this today. I am recognizing that we are about 15 minutes behind schedule. I'm gonna make the executive decision to go through the break. I think most people are in the comforts of their homes. And so I wanted to allocate adequate time to our upcoming speakers. And so I'll keep the introductions brief, but we're just gonna keep going so that we can give enough time for for our upcoming speakers. And so our next two speakers are Dr. Sri Shamasunder as well as Phuc Le. They are leaders in global health, founders of the HEAL initiative. For those of you who are aware, it's a remarkable fellowship where we are providing care both locally through the Indian Health Service as well as in many countries abroad. And so they are. There's so much that both of them do, and they're both amazing human beings. But I'll keep the intro down just for the sake of time, and we'll keep going. I've kept control over the slides because I've been told by Zoom experts there's less glitching to go back and forth. I apologize for the technical difficulties. Hopefully we won't have any more. So awesome. Dr. Shamasunder.
Thanks, Brad. Can you all hear me?
Yes.
Great. Well, that was an incredible intro by Natasha. I've been taking care of COVID patients this past week, and I think I learned a lot in that session. So thank you. So just a bit of background of Phuc and myself and the HEAL initiative, and I think a lot of this conversation, I just want to seed the idea of some of the inequities about how we think about disease, and as COVID-19 unfolds, how we keep in mind our vulnerable populations, the social determinants of health, structural forces that cause certain people to get sicker and have worse outcomes, all of these things that I think marries health equity that really leads the conversation in global health outside of global pandemics, and really centering that in the COVID-19 conversation. So just a bit about HEAL Initiative. So we are a global health capacity building fellowship that has existed for about 6 years now, and we have half of it's a post-residency fellowship, so everybody's fully trained, and half of our health professionals are US doctors and nurses, and the other quarter are Native Americans, and the other quarter are from low and middle income countries. So in the last 5 years, we've had 150 frontline health professionals across the world. And so we're across 9 countries and Navajo Nation. And so this last 2 days, we've actually had 2 calls globally. And this morning I was on a call at 7 in the morning and hearing from folks in Liberia, folks in Rwanda, folks in Malawi. In Rwanda, there's 36 cases right now, and they're trying to work on social distancing. In Haiti, we have a nurse leader who is taking care of the first 2 cases of COVID-19 in their hospital. And so, it's a hospital with that has a lot of the ventilation capacity of the whole country. And so there's 64 ventilators in all of Haiti for a population of 11 million people. So as we think about this global pandemic and, really China and Italy and now the US that we hear so much of, and of course Iran and South Korea, this is it, as this kind of moves into health systems that have been stretched at baseline and workforces that have been really stretched at baseline, understaffed, overwhelmed by the burden of disease. What does that look like? And I think thinking about that globally is important, and also thinking about it for our most vulnerable populations in the United States is important. I think taking care of COVID-19 patients this past week in the emergency room, there's a 10 a.m. huddle every morning, and the conversation of what is the plan for our unsheltered population, our homeless population, how are we going to manage them? And right now, it's really not a very effective plan. It's maybe admit them earlier, and it's thinking about trying not to send them back into the community. And so, we've seen around the country, whether it's Seattle or other places, there's starting to be conversations of how do we use, and even in Santa Clara County, how do we use motels, hotels, basically reconfigure a lot of the resources that we have to house these populations. So I think it's interesting. Next slide, Brad. In the setting of that, it's interesting to see what we are able to do as the centers of power get affected by this global pandemic. And I think one thing that I'm always reminded of is that, those of us that work in the global south and work in very underserved communities, the amount of preventable death that happens on a daily basis is profound. And there's a partner site that we work with in central India that has 650 TB cases a day, and regularly people come in with BMIs of 13, 14. And when you start seeing BMIs of 15, 16, it starts to normalize you start to feel like that patient is actually not undernourished, when actually they profoundly are, because the baseline changes and what's normal changes. And so I think this is an opportunity in this global pandemic to rethink how we think about disease and vulnerability. And so I think, for example, tuberculosis, we know how to treat TB. It's, active case finding, it's a treatment of latent disease, it's a treatment of all forms of disease, and then it's patient support, tying tuberculosis to food and nutrition. If you're going to treat people and isolate them, it's appropriate antibiotics. And we know in the last couple decades, multi-drug resistant TB was often thought to be too expensive to treat. Oftentimes you have different recommendations for places like the United States and different recommendations for places like rural India. And so when we think about global norms, I think TB is a good example where some of the ways, the point of care testing hasn't really emerged. And often I think the global health lens is that when, a lot of global health is targeted at keeping diseases that emerge in the periphery and amongst poorer populations, amongst populations that aren't thought to be as important as the centers of power in the metropolises, then they're not paid as much attention to. And so, next slide. And really, the structure of global health, I think, is almost by design that we see very weak health systems around the country. And now I think this global pandemic, clearly it started in China, which has incredible testing capacity, incredible amounts of resources, and scientific capabilities. But, Fook and I were part of the Ebola outbreak in 2014. Responding to that, Fook was actually in Liberia along with our Heal fellow, who's a UCSF fellow. And at the time, she was asked to take a leave of absence to go work in Liberia during Ebola. And so I think that there's this disconnect with both how academic medical institutions think about global health and the way that global health was actually started for people like you in academic centers, like medical students and nurses that were interested in global health. That was the target audience. And so when outbreaks happen around Ebola and in West Africa, there's actually this tendency to pull back instead of lean forward. And so, even on the global level, the World Health Organization that started as you all know, after World War II in 1948, its goal is technical support. Its goal is to target epidemics and epidemics that are in the peripheries from reaching the centers of power. And I think that the way that global health foundations have been structured have also been incredibly colonial. The history of global health is really a history of colonial medicine and the colonial powers of England and the like that used international health, tropical medicine initially to prevent their own colonial folks in India, in other parts of the world, from getting sick themselves. And so you have this orientation that really hasn't shifted that much over time. And so I think as the last speaker said, as we come into a more global world, how do we really start to understand the global history of the WHO, of a lot of our institutions, and how they've shaped the conversation over time that makes, when I'm talking to some of our frontline health professionals in Haiti and Rwanda and India, the fear around this as the health systems are much weaker than what we've seen in China and Italy and the US, and it's bringing these countries to their knees. How is it going to look in some of these other contexts? And so, the history of smallpox is important to know, because we recount smallpox as an incredible success effort, and in fact, of course, it was. In taking a disease that ravaged many people, killed many people, and erasing it from the planet, of course, is a huge success. But one of the vertical approaches to disease that smallpox started off, and it preceded with other diseases, but in all the efforts that happened around the world, there was actually no health system strengthening that was left in the wake. And oftentimes there's a great essay called Coercion in the Last Throes of the Smallpox Outbreak. That's an essay that talks about some of the eradication efforts in rural India at the time. And for a lot of folks, that their communities, and this happened in Ebola actually in West Africa too, their communities are dying of malnutrition, of malaria, of TB, of HIV, of malignancies. And you have this entire massive international cadre of health professionals that come to vaccinate against smallpox to approach a specific disease like Ebola. And for the population, the community that is suffering on a day-to-day basis from a large breadth of burden of disease, that it's hard to wrap the mind around, like, why is there so much interest in smallpox when our family is dying of malaria or visceral leishmaniasis? And so I think that smallpox actually failed in the sense that we didn't build health systems in the wake of smallpox. And then, Alma Ata is a declaration that I think hopefully I wasn't familiar with as a med student or a resident, but it's an important document for global health, and it's actually a conference in the former Soviet Union in 1978 that kind of laid out the idea of comprehensive primary care. And so it came after the throes of decolonization in sub-Saharan Africa. And if you think about in sub-Saharan Africa and other countries coming out of colonialism in the 1960s, a lot of them were trying to support their population with a strong, health system. But due to, I think, a few forces where, to have enough money to tax your population, the population is incredibly poor. You have the choice to go into debt. So a lot of folks were going into debt with the World Bank and the IMF in order to fund their health systems. And oftentimes part of the deal with those agreements was that you would actually underfund the social sector, and then or you try to nationalize your resources and whether it's oil or diamonds or others, and then pay for your healthcare. But that coming out of decolonization in the 1960s, it was actually sub-Saharan African countries had about $5 per capita to spend on healthcare. And what are you going to do with $5 per capita? It's really leaning into vaccination programs. And so Alma-Ata was this moment in 1978 where a lot of global South countries, poor countries, raised the question of how do we focus on comprehensive primary care and how do we really build health systems. And quickly, that was in 1979, there was a paper by the Rockefeller Foundation and others that talked about, well, that's a great ideal to build comprehensive primary health care, but that's too difficult and too expensive. And so you really saw global health foundations shift to a more vertical approach with primary health care, selective primary health care, and this idea of GOBI-FFF, which was like measuring growth, focusing on breastfeeding, and then family planning and the like, where it was a very measured package around what they thought was a more cost-effective way to treat underserved and poor populations. So the matching of what the global burden of disease with what the approach was for a lot of these communities is, why we haven't seen strengthening of strong health systems. And so, the HIV movement is also obviously very important for UCSF and San Francisco. And also it was the marking of solidarity between where these centers of power in San Francisco and other parts of the world to really align, this idea of like, what is the burden of disease and how do we build the health system? And as we know, even with the HIV movement in 1996, when we started to get HIV drugs coming out in the U.S., the goal in a lot of poor parts of the world was really to observe and prevent and essentially let a generation die because treatment was thought to be too expensive. And so it wasn't until 2003 with PEPFAR, which was the President's Emergency Plan on AIDS Relief, which Dr. Fauci actually was part of the Bush administration at that time and really orchestrated that, way back in 2003. And so he's clearly an incredible leader of this time. And so I think AIDS marked the first part where we thought about how do we build health systems in these contexts. And so really going forward, I think as we pay attention to COVID-19 and as it spreads, every day you can see the more and more countries that it spread to. And in a lot of these poor communities, we don't know if it's really, they have a low case load or they just have no testing. Our Nepali fellow this morning was saying, we have no testing. And so how do we know that there's cases or there's not cases? And so some of the tried and true methods that the previous speaker was talking about isolation, quarantine, active case finding, all depend on, testing at the point of care in order to determine how are you going to do contact tracing? And right now, I think that is an unknown in a lot of countries around the world. Next slide, Brad. So I think the South Korea example, there was an article in the New York Times, I think yesterday or the day before, that really highlights South Korea is almost like version 2.0 or 3.0 of what global health and a lot of our global health communities have really mastered. And I think that we can learn a lot from South Korea's example, and also a lot of the global health, global South countries that have faced all types of outbreaks and epidemics. So, really, South Korea did a ton of widespread testing. It's been very popular in the press to say that they're testing close to 20,000 people per day. And, South Korea had drive-by clinics and I think they still have that, where you come in, you drive with your car, you stop, and it takes about 10 minutes to get tested. Nobody gets out of their car. And this is, the 2.0 version of what we saw with Ebola in Liberia and other diseases, where you have a strong network of community health workers that will go and are trusted by the community. And so that's another piece that South Korea has a lot of public trust from to their government and their health system. And so the population really has adhered to a lot of their recommendations, as opposed to the US even, which doesn't have a very strong public health system. And you see some of the cynicism and the questioning of some of the recommendations. And so widespread testing, close to home, I think that going back to that example of TB, you can't wait passive case finding is not effective. It really has to be active case finding, where you're going out and finding those that are vulnerable, finding those that are symptomatic. And then contact tracing, one of the quotes in the New York Times article is like, we did our epidemiological investigations like police detectives. And so there's just an incredible amount of data that, is almost in some other times would be considered a surveillance state, and even during this time is considered a surveillance state. But infrared thermometers in different buildings, as people come and go outside of buildings, they're tracking credit card track records. So if a person comes down with a case of COVID-19, all the people that they could potentially been in contact with, and really tracking, if they were, who are the people that they were in touch with for more than 15 minutes. And so based on like closed circuit cameras, what buses they took, what trains they took, when they came out of certain buildings, did they have a temperature, and then really connecting. And then the South Korean population would get text messages that said, you've been in touch with, you've been in contact with somebody who's COVID positive, and then they would go from there to contact trace from those folks that were exposed. And so you really see this like version 2.0 from what we know works in contact tracing around the world that South Korea has done. And the US doesn't have a great track record and the infrastructure to do this well. And then I mentioned kind of the trust, the public health trust that South Korea had. That's key, because like I mentioned, in smallpox and in Ebola in Liberia, like if people aren't honest and they don't trust government, a lot of people in West Africa we saw would lie about their symptoms, hide from health workers that are coming, and then contact tracing starts to fall apart. So next slide. I mentioned some of this, but really paying attention to as this outbreak unfolds, the vulnerable populations in our communities in the U.S. and elsewhere, where there's very few. I'm talking to a Heal fellow in India, and he's they're starting to have daily curfews in Delhi and other parts the country, and there's a ton of day laborers and the informal economy. How do you get them to? How do you have a economic package that allows them to actually not come to work, because that's gonna, they're surviving day to day. And so there's all these considerations in a country as populous as India. How are we going to do social distancing? The other considerations are with self-isolation, you have to combine food and water. A lot of these folks are food insecure. And so, how do you do wraparound services in some of these global communities, or even in our vulnerable populations in the US? Because just isolating at home if you're vulnerable oftentimes is a recipe for a disaster. And then I think what we saw in Liberia, the last point of repurposing government to build up bed capacity, we saw that in China. We saw that in Liberia during Ebola. The government takes a strong focus on building that. In Singapore, I think the public sector took over a lot of the private sector. How do you, in the US government, so far we haven't seen a demand for like some of the private manufacturers to stop activities and focus on PPE, for example, or other pieces. But what is the role of government? And oftentimes in a lot of these very under-resourced and overwhelmed and weaker health systems, you see the government kind of take a very, very strong role in driving the response to the pandemic. So I think that's my last slide. I'll stop there.
Awesome. Shri, thank you so much for sharing that global context and thinking about concerns regarding equity globally and the devastating impact this disease has on countries and communities that don't have the infrastructure that we have as well. So thank you for providing that context. Shri, if you would keep an eye on the chat, maybe for the next couple of minutes in case questions come through. And we are running a bit behind schedule, so I'm going to keep things going and I'll keep introductions brief. Our next speaker is Dr. George Rutherford, who has really been a national voice in the context of this pandemic. He's a professor of epidemiology and biostatistics, and also the director of the Prevention and Public Health Group. So I'll keep intros brief, but Dr. Rutherford, are you on?
Yep, I'm here.
Great, awesome. So feel free to just say next slide and I'll keep things going.
Next slide. And next slide, please. So just to review current epidemiology, and please forgive me if I'm repeating things, but there have been almost 400,000 cases reported from all over the world as of this morning. 4.4% of those people who've been reported have died. That's of course not the final case fatality rate, which I can talk about if there are questions. Only 23% of the cases are from mainland China, and most of those were from a single province called Hubei, which is where Wuhan is, which was the epicenter of the epidemic in China. The epicenter's now moved to Europe and to North America. Currently, 17% of all cases are from Italy, but more than a third of the deaths, with Spain, Germany, and France also heavily affected. And then the U.S. With 46,000 cases as of this morning. A couple of other countries that Shri talked about briefly: South Korea, which is being held out as a model for how to do this, understanding that their public health workforce is probably 10 times larger than ours per capita, and Iran, which has had a separate but interesting epidemic that spread regionally around the Persian Gulf. The next one, please. So this shows you the current, as of today, levels of disease in numbers of cases reported by WHO region. This kind of salmon color in here. So this is China back here, the orange. This jump here on February the 13th or 12th was because of a change in case definition. That actually would have been sort of kind of accumulated in the prior curves. They moved from using testing using chest CT scan as a diagnostic tool. This little tail back in here is the Korean epidemic. And then we have Europe, Middle East, Eastern Mediterranean, which is largely Iran, and now the Americas. You can see how the Americas have come out of nothing over here over the last 4 days. The next, please. So the sustained transmission out of China, just to say 2 words more about South Korea. The focus, as Shri said, has been on massive isolation of cases, contact tracing, and quarantine of contacts. There's a great article in the New York Times, as you mentioned yesterday, that talks about how this fits into Korean culture. There's also fines if you violate quarantine. But interestingly, not only has there been a diminution in transmission, which is reflected in fewer cases, but the case fatality rate, which is probably a relatively true case fatality rate, is lower. Now, the question is that due to earlier diagnosis? The care is roughly equivalent, whether it could be due to early diagnosis or whether we've just found more of the mildly symptomatic and asymptomatic cases, so you get a truer denominator. There's a little second wave back in here in later March, which was centered around a call center in Seoul. So you can see how you can have outbreaks that pop up from time to time as well. The next, please. And just to mention, Italy with sustained transmission out of Italy. This is going to be the Pulitzer Prize-winning photograph this year of an ICU nurse falling asleep at the workstation. There have been lots of cases, and the number of cases that have died is almost 10%. It's concentrated in the Lombardy region, which is where Milano is, and Italy's elderly. The entire country was placed in lockdown, which in public health is called a cordon sanitaire, with only the handful of things that are open. And those have even tightened up now. They've stopped public transit, I believe. The ICU capacity is wildly strained, and it's on the edge of what's called austere care, which is a military medicine term, disaster medicine term, meaning the healthcare workers choose to choose who gets what level of care. Finally, there was somebody and so they upped the ante, closed some more, and moved the military in because the local police didn't have the person power to enforce it. So it's being heavily enforced now. The next, please. In the U.S., we're now number 3 on the list of countries. We have deaths. A large number of these are presumed local transmission. They're clusters in, I'm sorry, I got the wrong graph in here. These are what happens when you do these in the morning at 5 a.m. They're clusters in Westchester and Boston, and the epicenters moved from Washington State early on to New York City and northern New Jersey now. Almost half of all U.S. cases are in New York, and 157 deaths, which will catch up over time. There's been this huge crush over the last week. Governor of New York, I was listening to his press conference earlier today. They're desperate for beds. They're desperate for ventilators. They see a wave coming in 3 weeks, 2 to 3 weeks, that they will not be able to handle. There's some interesting things in Washington State, which is where it appeared first in a nursing home, which is as you can imagine, a prime locale for transmission. And the models had suggested that before that had appeared, the virus had been circulating quietly for almost 3 weeks, with maybe 1,500 people infected even before the first cases came out of that cluster. The next one, please. This is where you can. This is as of this morning, the CDC thing as of this morning, and you can see where cases are concentrated in different places, with the bulk now in New York and northern New Jersey. There's interestingly an outbreak in New Orleans now, which I can't help but believe would be tied back to transmission during Mardi Gras. You should be thankful, by the way, all of you in the listening audience, that the shelter-in-place order came at midnight before St. Patrick's Day, or else we would likely have a lot more cases. The next one, please. This is the first US series that was published. And one of the things that caught everybody's eye were these bars down in the 20 to 44-year-olds, where people are getting hospitalized, where there are even ICU admissions and mortality. And it's like 1 or 2 cases. But you can see the same pattern of increasing mortality as a proportion. These are absolute numbers as people get older. The next, please.
So, Dr. Rutherford, would you prefer to take questions in real time or at the end? There are some
No, sure,
questions that are public. So
I'm a neophyte at this. I've done a few of these, I have to admit. The first one I did of these remote learning things, I did at Berkeley and I fell asleep in my own lecture. But you know, that was a bad sign.
So
Yeah, real time's fine. Real time's. Go ahead, Brad.
So at the slide change, I'll read the question so that this is being recorded, so folks afterwards can hear the question.
Yeah.
You mentioned that the Chinese review of the Italian response mentioned no masks. Is this referring to healthcare workers or universal masking in the community? Were there to be adequate supply? What's the evidence regarding universal masking?
So the universal masking, for which there's no evidence aside from what different people do things differently. Universal masking is not N95. It's not to prevent you from getting infection. It is to cut down on you transmitting if you happen to be infected. And I think we might go there as we move away from shelter-in-place, the shelter-in-place orders. It's a sort of in-between intervention. There is some evidence from a randomized controlled trial conducted in the US and outpatient clinics that N95s and surgical masks are roughly equivalent in terms of preventing transmission of disease in medical settings. But if we do that, the message is going to be, this is because because of asymptomatic infection, one has to presume that one is infected when you go outside. So the next one, please. In California, we have 2,220 cases and 43 deaths. These data are from the state, and they lag way behind on assigning whether it's local transmission or not. There's probably at least 75% of this represents local transmission. The next, please. Interestingly, in California, this is a genetic map, obviously, of COVID-19 or SARS-CoV-2. Interestingly, in California, there appear to have been different introductions at different points in time. A Solano County cluster, a San Benito County cluster. Both of the San Benito came from a person returning from China and who transmitted to his wife. The Solano cluster was probably the first case of community transmission in the U.S. And you can see how we're seeing it kind of, as opposed to Washington, where there was a really kind of very clear single cluster with a single introduction. In California, there have been 3 or 4 or 5 different introductions. The next one, please.
So question here, do N95 and or surgical masks help the wearer from getting COVID-19 at all?
N95s do, but it's N95s plus. You have to have eye protection as well because of the conjunctiva are part of the respiratory epithelium. If we had enough N95s for everyone and people would wear them correctly, which they don't, and we could fit test everyone for them, which would mean the end of beards as a fashion statement, by the way, because you can't have a beard and have an N95. We could do that, but there are nowhere near enough of those, and they're being reserved for prevention among healthcare workers and in certain very high-risk places like maybe homeless shelters for staffs and staffs in long-term care facilities. Okay, the next one, please.
And one more question here. How long are masks viable?
Depends on what they are. In the old days, and I'm talking 50s, 60s, masks were made out of cloth and were washed and reused, and then could last several washings. I have a picture from SARS in China, the original SARS in China in 2002. where everybody's using reusable masks. Now we will use N95s for a day or longer. Face shields, which are the kind of the face helmets that come down in front of your eyes, are used basically are cleaned with alcohol at the end of each shift and are continuously reused. Now, would we like to have disposable everything? Yeah, we'd like to have disposable everything. We don't have that luxury. Okay, and then just a couple of words about transmission, please. The next one, please. So we got two things going on here. We have polymerase chain reaction, PCR, which amplifies RNA, okay? And that's a test that we use to look at the, to look for the presence of the virus, and that's what's in the nasal swabs, okay? But the problem is that PCR doesn't tell you whether the virus is viable or not. You're just finding pieces of RNA. So there was a CDC published last night online, an MMWR article about the cruise ships, and they said that they were able to recover RNA by PCR 19 days later when they were cleaning the ships. That's not viable by any stretch of the imagination. You have to try to make claims about whether a virus is viable. You have to be able to actually recover the virus and culture it. PCR is a problem because that's what we're following. And if you look at the y-axis here on the upper right-hand thing, you can see how the scale goes backwards. That's because CT is cycle time. It's how many times you have to run it, how many times you have to replicate the RNA to find it. So the fewer times you need to run it, the higher the viral load is. The more times you have to run it, the lower the viral load is. And there's a kind of convention that 40 cycle times means you're not going to find it. You can see here how after onset of symptoms, they're fairly high viral loads, and then they fall pretty quickly, so that by around 9 days post symptoms from nasal swabs and also from throat swabs, there are low levels of virus by PCR. Now, next one, please. But to ask about what about shedding viable virus, there's one study that looks very specifically at this, and they were able to recover viable virus after eight days post symptom onset. So I think that's what we're probably thinking about mostly, and that's certainly what those of us who are doing planning and looking at things like quarantine periods and how long to keep people in the hospital. This is a number we walk around with in our heads. The next, please. So there are a couple of other pieces here. Between 75 and 85% of transmission in China was in family clusters. And the majority of cases arise from close contacts of symptomatic cases, with 1.5% of close contacts in China to actually developing and getting diagnosed with the disease. The secondary household attack rate, I mean, if you have somebody in your household with COVID-19, 10% of people would get it in the household. That fell to 3% later on as they got better at recognizing infection and moving patients into isolation. There was transmission in closed settings, things like nursing homes, prisons, health facilities, but but that was not a big driver. And then finally, transmission in school was not observed in China. There are two things going on there. One was the outbreak took off just at the start of the school holidays for the Lunar New Year. And so when it was taking off, the kids were already out of school, like for Christmas break, right? And then they stopped and just kept them closed. So they didn't have a lot of chance to observe transmission in school. The other thing is that children and adolescents are far more likely to get mildly symptomatic or asymptomatic disease and are quite unlikely to present for medical diagnosis. But in the lessons of influenza A is that elementary schools in particular are huge amplifiers of transmission. There was a question, Brad?
Yeah, a question came up regarding the mask conversation. Why is there a difference in mask effectiveness for preventing acquiring the virus versus transmitting the virus?
So think about sneezing or coughing, right? Just think about sneezing, right? They have these. Have you ever seen these shots and they're backlit, and so you can see this sort of plume of respiratory particles, as we say politely these days, out in front of somebody. Those are the respiratory droplets we talk about all the time. Think about your breath on a winter day when you can see your breath. Those are the respiratory droplets. If you're expelling them forcefully, sneezing, coughing, where they go farther, right? The masks just sort of knock it down, right? They're not going to be perfect, but they're closer to your face, and the mesh is constructed so it's picking off droplets rather than individual viral particles. The N95s are much more tightly woven and can prevent stuff from getting in. Think of it as sort of like a physical barrier as much as anything. It's probably as good a barrier as putting a handkerchief in front of your face. It just cuts down on the droplets, the number of droplets in the environment. So it's kind of a debulking sort of thing. Whereas the ones you wear to not get it, you want to make sure it gets every single one, which is why it has to be so fit tested so carefully. Thank you. That's a good question.
Couple questions that I'll share here, and then there's a bunch coming through. Maybe I'll take 2 or 3 of these, and then I'll keep moving forward.
Fire away.
How much should we trust the reports about how long coronavirus lives on surfaces, given your comment on PCR positive that may not be viable, such as on the Princess cruise ship?
Yeah, they're about PCR. Okay, they're correct. You can recover on these different surfaces by PCR. The practical application of those is it's practically nil on one hand, but on the other hand, it makes the point there is fomite transmission. There's clearly fomite transmission of this virus, meaning it gets on the surfaces. People touch the surfaces, then they rub it in their eyes. Okay, and they don't do it on purpose, obviously. So that's a clear message that we send out. Assume that surfaces are contaminated. Wash your hands when you go into public and touch surfaces, like on Muni or something. But the actual longevity of viable viruses has not been. Let's see. I'm sorry. Some of there was one article that did it in perfect laboratory conditions with perfect temperature and humidity, and they could recover it for some period of time afterwards, sort of on the order of several hours up to a day or two on certain types of surfaces. I remember it was 4 hours on copper. Thinking, why would anybody care about copper? They carrying around pennies or something. But I guess it's some perfect copper bar at some perfect restaurant someplace. But discount the absolute numbers. But the larger point is that there is fomite transmission.
Great. I'll take a couple of these questions on transmission, and then there's another question about number of cases. So back to the masks, there was sort of 2 questions. One is, why wouldn't a surgical mask or bandana help prevent you from getting it in light of the droplet discussion? And then there's another question about the virus staying in aerosols for up to 3 hours. And there's been a lot of discussion, as you know, internally that in the absence of aerosol generating procedures, UCSF has taken a stance that N95s are unnecessary. And so there's a lot of there's some confusion here that abounds. So the sort of 2 contrasting questions is, with the droplet discussion you just had, why wouldn't these other masks be effective? And then there's another question about the aerosolization of particles.
Let me answer the aerosolization one first. The same article that was looking at recovery on a variety of surfaces in perfect laboratory conditions also created a sort of unrealistic, an unrealistic scenario for creating aerosols, and said they could recover. Aerosols means that the virus is suspended in the air, right? It doesn't fall. And so they're, instead of coming out on droplet nuclei, they come out as individual particles or on finer nuclei. So the problem with that is that if there were aerosol transmission, or if if aerosol transmission were a predominant mode of transition, there'd not be 70,000 cases of COVID-19 in China. There'd be 1.4 billion. It would be impossible to stop. The CDC, I'm sorry, the UCSF guidance is not kind of something UCSF puts forward. It's CDC guidance, it's OSHA guidance, it's WHO guidance as well. But in procedures like intubation, pulmonary lavage, pulmonary toilet, suctioning, things that generate aerosols, because you're deeper down into the lungs and there's not this chance to adhere to respiratory particles. That's fine. That's totally reasonable. So that's that answer. Why don't surgical masks prevent you from getting them? They prevent you from getting them, sort of. But if we're looking for almost absolutes here, in the great sort of planning exercise that goes around these kinds of epidemics, the one asset we can't lose are healthcare workers, and we can't lose them to quarantine. We can't lose them to sickness. We need to preserve them at all costs. So we want the best possible, even though there might be some other alternatives. Fair? Okay, Brad?
And then, yeah, that sounds great. And then I will take these two more and then we'll move forward. One is, we are constantly touching our cell phones. What are your thoughts on transmission from cell phone screens and cleaning them?
Don't. Okay, yeah, go back to my generation where phones had cords on them and rotary dials. Not even Brad knows what I'm talking about. You should clean your cell phones. I don't know how you're supposed to clean them. I would guess Clorox wipes, but who knows how it interacts with the plastics. I'm sure there are instructions one could find online. Don't touch your face. Okay, now that's a hard thing to do, and right now I want to scratch my nose, but I'm not going to do it because I know you guys are looking at me. So you can do this stuff, right? And there was some interesting stuff in the New York Times about which has become my favorite scientific journal, about how to kind of cue yourself not to touch your face. One was to use scented soap. So as you brought your hands up to your face to do it, you'd smell it and you'd have this olfactory stimulus not to do it. I thought that was a great idea. You can play with your ears all you want. Okay. So that answer that question, Brad?
Yes, and then I'll take the final one, which is going back to case numbers. Going back a few slides about the conversation about California.
Yeah.
There was an article in the New York Times yesterday that made the point that California lags way behind New York in terms of testing. Given this is the case, what do you estimate as the actual case numbers in California, and when do you think the cases will peak?
So I would estimate, I can only speak to San Francisco. California is acting like three separate epidemics. One's in the Bay Area with a predominant focus in Santa Clara County. One's around Sacramento with the sort of Sacramento, Yolo, Placer counties, and one's in Southern California. And they all went to quarantine, all went to lockdown at different times. And I would estimate that in the city and county of San Francisco, there are about 1,000 people who are infected. We think that there is not a lot of ongoing transmission, and that we would see a peak, and this is just me saying this is not official anything, in 2 to 3 weeks, and that it's going to peak with that. We've managed to flatten the curve here. Now, look at the daily case counts from San Francisco, and you can find out if I'm right or wrong. We've had about 24 a day for the last couple of days. Los Angeles is gone from sort of progressively up to more than 100 cases a day yesterday. So our hope is that we're actually starting to see this now. Okay.
That sounds great, and I would agree. I mean, we are turning. We have had limited testing, and we're seeing that on the front lines. And so
the testing. I'm sorry. Yeah. The amount of testing has been relatively constant over time, even though it's ramping up now. So I mean, I think you can kind of compare. The numbers are roughly comparable over the last few weeks, and so we really do sort of see a shape of a curve. That's flatter than the exponential growth. it's going to be hard to sort out what's going on as testing becomes more and more common. But remember, what we're doing is what we're really counting right now are people who are sick and are sick enough to present for medical diagnosis. And we can also count numbers of people in the hospital, and that's also relatively flat. That's another point of counting that you can do for surveillance. Ready?
Yep.
Next one. So our two strategic goals are to limit the new cases by decreasing the effective reproductive number. That is the number of people who are infected per each case, and then flatten and prolong the outbreak. First of all, to make sure we have enough healthcare resources, and secondly, to buy time for antivirals and eventually vaccine. The next, please. This shows you how we put together the effective reproductive number. It's the number of contacts per day, which by staying at home goes way down. The probable infections per contact. This is about PPE, washing your hands, not touching your face, all that sort of stuff. We'd like that to drop. The infectious period, that's a bit more abstract in this sense, but we can limit the infectious period on average by moving people into quarantine, or moving people into isolation. And then population susceptibility really is a function of vaccination or having naturally acquired immunity. Next, please. So this just shows it, I'm sure you guys seen this a million times. This just shows it graphically with the dotted line, dotted horizontal line representing the healthcare capacity. Just watch CNN tonight when they replay Governor Cuomo's press conference. You can really hear the desperation in his voice. Next, please. So these are modeling. So I spent a lot of time modeling, and modeling for this has been, we built models both forwards and backwards. We have pretty good numbers from Wuhan that I think we can trust to make predictions, and that's what we're doing. What we know about from Wuhan was that most of the infections in Wuhan were transmitted by people who had not been diagnosed. That is, they were less symptomatic. They were mildly symptomatic. They were asymptomatic up until the lockdown date, and then that fell dramatically. Okay, we think that people with undocumented infection, meaning undiagnosed infection, meaning they're not sick enough to present for medical care, are less efficient transmitters. But because there's so many more of them, they were counted for the big bulk of the cases early on. Down on the right-hand side, these are the famous Imperial College models that are looking at the impact of various mitigation strategies and when the peak curves will come. And down at the bottom here, on the bottom of the red line along here, this is all United Kingdom. This is their bed capacity, all right? So that trouble in River City. So this is where we are here. We're doing all this case isolation, home quarantine, social distancing. We are in fact doing a lot more than this, and our curve is going to look much flatter than even this. Next one, please. So how do we prevent this at the population level? We have containment, which are all the things that I heard Sri talk about from South Korea: isolation, quarantine, infection control, all the basic activities that we do, and individual measures to increase social distancing, like telling you not to stand next to people who are coughing and sneezing on Muni. Mitigation is what we're doing now. These are community-wide measures: telecommuting, banning large gatherings, business, school, and transit closures, widespread community quarantine or shelter in place, which is what we're doing, and then a whole variety of border closures. The U.S. is now essentially closed. And Hawaii, by the way, is also closed. You have to go through a 14-day quarantine when you come into Hawaii. Next, please. Okay. What did we learn in 1918? Now, I don't know if I'm slightly unclear where you guys are in the Bridges curriculum and whether I talked to you about public health and big epidemics of the past. This is the big epidemic of the past, the 1918-1919 flu. And there was very interesting work done by a history department at Harvard and McGill that pulled all the mortality data from 43 North American cities, and then looked at all their kind of interventions. This is probably the starkest one. And they were looking at closures and the effect of closures. And it's interesting to see what mass gatherings were in 1918. Billiard halls, Sunday schools, cabarets. I love all that stuff. Philadelphia didn't put their, I'm sorry, I don't have the when they did what on here. Philadelphia didn't put their closures into place until they were at about 100 excess deaths per 100,000 population, where St. Louis started right from the beginning on the red line, kept them in place. And then back in here at the end of November around Thanksgiving, they took them off. They took their foot off the brakes, and there was a rebound. And we're all very conscious of that experience, because the question is when do you stop shelter in place? What replaces it? What's almost as good as it? Are we ready to do that yet? All those things. So begin social distancing interventions early. Keep them going throughout the outbreak period. Next one, please. So are we going in the right direction? It's always a good question. Can you see my cursor, Brad? No?
No.
Okay. So there's the U.S. in the middle. And you can see South Korea peeled off to the right. Japan.
It sounds like some people can see it, yes.
Yeah, okay. So here's the U.S. here. Here's this sort of 33% daily increase. Here's China that's only just now started to peel off. South Korea peeled off very early. And then these other places, Hong Kong, Singapore, and Japan, had early experiences with pretty reasonable disease control. The rest of us are kind of on this path here. So we want to go from here over to the right-hand side of the curve. Okay, next one, please. And the way we're doing it is not the way that it needs to be done. This looks at testing per million inhabitants by country. This was as of earlier this month. And you can see how much more South Korea has than anybody else. And here's the US sort of third from the bottom. We're just slightly more than Vietnam. So testing. And testing is good. Why? Testing is good because, first of all, if we have rapid tests, we don't have the hospitals full of people who are there to be ruled out as having COVID-19. They can be kept there if they're symptomatic with other forms of pneumonia. But if they don't have COVID-19 and are medically stable enough, they can go home and we don't fill beds up with them. So that's one reason you have to have a lot of testing capacity. The second reason, and then also people who actually do have it, you want them to test negative before they get discharged home or get sent back to isolation. The other reason you need it is for identifying people, right? And so right now we're limited to, because of testing and person power availability, we're limited to doing household contact investigations. Just so you don't have enough people to do them, and we don't have enough testing capacity to do them. As we come out of shelter in place, we think we'll see more and more community contact tracing. And as Sri said, there's all these gizmos out there, some big brother gizmos. My favorite is following cell phones around. One of the projects we're working on is to get patients, people who are diagnosed, to consent and then follow their cell phone movement during when they were likely infected and also likely to be most infectious. So if we find out they're on, at the Safeway there on Church Street and Market during a period of maximum infectiveness, then we can also look to see other cell phones, not people, but just cell phones that were there at the same time, and ping the phones and say, oh, by the way, you should come in and get tested, and then do that again and again and again. So there's some really kind of fancy tracking things that are going on now. If we go to wearing masks, interestingly, facial recognition software doesn't work anymore, by the way. So that's the part about decreasing transmission. What about decreasing mortality? I thought this was really quite chilling. And this is looking at mortality in cities and towns in Hubei province, over here on the left, versus other provinces in China. And what they're able to construct is a curve, and the more cases you have, the greater the mortality is, right? So that's probably reflecting hospital capacity. The more cases you have, the more likely you are to exceed capacity and move to less than ideal care and have worse outcomes, which is, I think, exactly what they're experiencing in Italy now. The next one, please, Brad. Okay, just to say 2 words about impact. We can skip through this because I realize my time's up. This is there's actually the order. There's an actual order there. This is the most important slide here. These are 2 provinces. So in Italy, things are in regions, and then below the regions are provinces. These are 2 provinces in the region of Lombardy, which is the most affected area. Lodi, which I have to think to not pronounce Lodi, but Lodi was a place, and you can see in this gray bar, that instituted. It was actually, that was the epicenter of this northern Italian epidemic in a town called Costogno. They instituted sort of shelter-in-place interventions early on, as opposed to Bergamo over here, which did them much later, right? And you can see now, a couple of weeks later, these guys are having, 50 cases a day, and these guys are having, 350 to 400 cases a day. I think it's quite a remarkable contrast. And even though I'm from Southern California and I'm always defensive about Southern California, I would think that we're probably going to start seeing these graphs in the Chronicle between how much we've done versus what they've done. Okay, next, please. And days make a difference in this. This was the smartphone. This is another smartphone application. This is looking at how much people have traveled. Blue is traveled much less than normal, and the sort of yellow oranges are, how much less travel there is. And you can see how tight the Bay Area is and how quickly it moved to not traveling very much. Okay. This is the day before St. Patrick's Day. This is St. Patrick's Day. Okay, next, please. So let's just, you guys know all this stuff. Just keep going, please. Oh yeah, okay, so here's the other thing. What are we seeing? We're seeing in the Bay Area versus the rest of California, we're seeing a little bit of stability in outbreaks, whereas the rest of the state continues to rise. Here's San Francisco in particular, specifically. And we're having, as I said, 23, 24 cases a day. That's, so we're looking a little flat. So follow that. The best place to look at this is the Chronicle website has a tracker. That's where I get all my data from. It's much better than the state website, and it's much better than the CDC website because it gives you that fine detail. You guys know all this stuff. Let's go. Let's just keep going forward. Oh yeah, this is my favorite thing. I don't know if you guys ever go by the Grand Lake Theater on Grand Avenue in Oakland, but this is what was on the marquee last weekend. So with that pleasant note, happy to take more questions.
Great, that was extraordinary. Thank you so much. Let me take a couple of questions. For those of you who want to take a 5-minute break, feel free, and we'll just field questions during the 5-minute break here. So, here's a question, and I actually had a very similar question. I'll read this, but the framing here is you've been seeing editorials in the New York Times, the New Yorker, and our chief administration really talking about this concept of the cure being worse than the disease. And so here's the question as it was framed, and there's a follow-up.
Right.
Today, the federal administration is stating that they expect the country to open up and for people to return to work by the end of the month. There is a growing narrative over the past 48 hours that is encouraging people to return to work, participate in the economy as soon as possible. What are your thoughts on how realistic this timeline is? What are the consequences, versus benefits of decreasing social isolation and shelter in place next month? And a follow-up to this is it possible that if the federal government opens, can SF extend their shelter in place if they want to?
So the answer to the last question is absolutely. Public health laws in the United States are state laws. In California, most of the power is relegated to the local health officers, which are mostly in counties, but there are 3 city health departments as well: Berkeley, Pasadena, and Long Beach. So the 61 local health officers are the ones who actually hold the authority to do this. So absolutely, positively. And it hasn't come to this, but I fully suspect that the United States government, the federal government, has no power to order this. It would have to be done by states or local agencies. What happens if you take your foot off the brake too early? You get a rebound, as you saw in St. Louis. I think that's a real clear example. And you will have wasted this 2 weeks for nothing, which I think would be a huge mistake. It's all in the land of wishful thinking that nothing bad will happen. Sorry, because I actually couldn't resist that time. And the other part of what happens if why shouldn't we do what the Netherlands did, which just let it run its course and try and protect the elderly? Well, to start with, it is, first of all, as you saw from US data, there is morbidity and some mortality in younger age groups. The other thing is there's a supposition that you have lifelong immunity from this, that you would acquire lifelong or long-term immunity, which no one really knows. So that's a big bet to let an epidemic run wild and run through a population. I mean, it's, 50 years ago or 40 years ago when I started doing this stuff, this would have been some weird pneumonia of unknown etiology. And we would have been curious about it and tried to culture it and written articles about it. We have the ability to follow these things in real time now, which as much as anything gives us the ability to sort of ups the ante about doing interventions of this type to prevent mortality. We're going to see a real example of this here because this is not being done in the Southeast at all. They don't believe this stuff at all. And I think, to place, say, like Florida with a large elderly population, you're going to see a lot of mortality. So we'll see. We're going to have experiments of nature here soon enough.
I'll take 2 more questions here from the feed, and we'll move to our final segment of this seminar. And I'm going to frame this actually. I'm on a lot of pediatric listservs as well. I'm MedPeds and I take care of kids. And there's along this lines of understanding the disease outcomes of loosening these restraints. There's a lot of concern about the devastation, the financial devastation. We know intimate partner violence goes up when there's economic distress. We know suicide, depression, anxiety with economic distress. And it's the people at the margins who are really suffering the most at the hands of these social distancing, isolation, shutdown policies. And so there's among a very thoughtful physician community who are some of the strongest advocates I know. I'm seeing a lot of them come around and say, like, can we have a more surgical approach to this problem? This, the potential sort of adverse effects of having kids out of school for weeks to months on end. This concept of intimate partner violence, suicide, depression, economic hardships. We know our undocumented community is suffering tremendously. And so I don't know, how do we balance the idea that yes, the disease will be worse, but are these measures unduly harming our folks at the margins?
This is why we have elected governments to make these decisions, right? I would dispute your claim that this is hurting the most marginalized. In Oakland, a lot of the homeless have been moved off the street and into hotels. specifically because of this. There are, I think that there is a very specific series of efforts being made to protect the homeless. Now, the rest of the people, I worry about, guys working in the kitchen on the back of a restaurant just as much as you do. And I think that's one of the reasons that the shelter-in-place ordinance kind of kept restaurants open, to try and keep at least that segment of the industry keeping its head slightly above water. Yeah, it's a problem, and that's one of the things that the economic stimulus packet is supposed to address by giving everybody money. That doesn't help you if you don't pay taxes, or you're not a U.S. citizen. You're not going to see that. But I think there's a lot of federal money that's going to come in, and it's going to try and make it better. Yes, there's harm to the economy, but that's our fault, right? The Chinese took a huge bullet for us, kept us at bay for 2 months, completely decimated their economy. And what did we do? We said it wasn't going to come. We said it's just flu. We said it's like no big deal, right? And we could have had enough tests, which was just a complete failure of leadership. We could have had this procedures in place to screen people coming through airports with something reliable, as opposed to thermal monitors, which they didn't even do. I had more screening personally in February going into Malawi than coming into the United States. So it's, we blew the chance, and I think that having seen the kind of devastation that's going on now in Italy, you just have to look and see it. I mean, do you really, if we let the business sector go, that means we're going to let the healthcare sector go too. And we're not going to be able to take care of people, and the mortality rate's going to go through the roof. And there's going to be austere care where 2 people are going to be in the ED, and they're going to say, okay, you're 65 and you're 64. You 64-year-old, you get the ventilator. You 65-year-old, go through door B and get some morphine. That's what's going on. And so that's the cost of exceptionally poor leadership from the people who are supposed to be controlling the borders. And, and then the counties have to take it on, to their local governments have to take it on themselves. And they have to make these very austere, it's not in the same sense, but very difficult decisions about how much to try and avoid the shutdown of the medical system. Because we're not talking about just some little inconvenience. We're talking about every ICU bed, every med surg bed, every pediatric ICU bed being filled up with adult patients, period. That's what we're talking about. And that's in fact what's happened in Italy and is happening now in Spain. So how much more of a playbook do you need to understand that that's what the consequence is? So if you want to trade business for medicine, that's what we have elected leaders for. But that's the trade-off.
Wow. Thank you so much. Really appreciate your
I say
insight
that
here.
not quite as directly as that, but I say that on the press all the time.
Well, I appreciate it. If you're able to access the chat feed, there are some questions pouring in. I'd like to move forward out of respect and time for our upcoming presenters, and I will try to address some of these as well. But if you can access the chat feed, it would be great to respond to some of these as well. So
okay.
let me share my screen, and again, I'll keep the intros brief. It's my honor and pleasure to introduce Dr. Suresh Narayana, who is a hospitalist here at UCSF, who is the chair of the Medical Ethics Committee, and also one of our institutional leaders in social medicine, diversity, equity, and inclusion. And so really brings a unique lens as a provider who has cared for patients with coronavirus, and also has this sort of equity lens and ethics lens. So Suresh, thank you so much for joining us today.
Thanks so much for having me, Brad. Can you hear me okay?
Yes.
And sorry, the lighting in this room is not ideal. I basically look like a shadow, but hopefully you can still hear me. So I am here to talk to all of you about ethics and my role as the chair of the ethics committee here. I guarantee that this will be an unsatisfying presentation, as one, it's short and there's a ton to talk about. And two, as with any ethics presentation, we always tend to leave you with more questions than answers, but we'll do the best we can with the time we have. Brad, how much time do we have for my planning slides?
If we could do 15 to 20,
Okay.
that would be great.
Okay, perfect. And I have some time budgeted in the end just for your questions. And Brad, I'll have you manage the chat. Feel free to interrupt me if it's necessary. Otherwise, we can do everything at the end. Okay, so here's what I'm going to talk about, everyone. We're going to first talk about the ethical principles. I'm going to give you an umbrella framework, very similar to a framework you already know and are very well familiar with, many of which you've probably seen in execution in real time as it comes to clinical care, but how those principles may change in the context of a public health emergency, and then specifics on some triage and allocation. This is where it gets to the nitty-gritty potential horror scenarios that were described before, and then a little bit on moral distress in and of itself. So let's first talk about this slide here. So ethical principles. We all know that the four big ethical principles that we often talk about are respect for persons, or autonomy, beneficence, or non-maleficence, and non-maleficence, and justice, those four. And we have a classic representation of what that means, right? Do good, don't do harm, be fair, respect people's individual free will. This is a very, very grossly exaggerated simplification of what those principles are, but in general, that's what it means. Now, in the context of a public health crisis, though, they're applied slightly differently. So autonomy, for example, or respect for persons. There are certain public health mandates, as you have all seen and experienced yourself, that may justifiably impose constraints on individual patient autonomy and liberties, or individual person autonomy and liberties, right? So in our social contract, we have all agreed that we are going to try to obey a shelter-in-place order. That is for the sake of the general public good. There is an ethical principle that allows for that. In the context of patient care, that might manifest as, for example, placing a patient in isolation, whether it's for COVID or whether it's for tuberculosis. That is the idea, is that, yeah, that's a hindrance to their liberty, but this is for the general public good. So that's how autonomy can somehow play out in the context of a public health crisis. Now, beneficence, and including non-maleficence in here, this idea that as providers, and this is a very complicated issue, we are often taught to look at the individual in front of us, and our duty is to the patient in front of us. Now, in the context of a public health crisis, however, that changes a little bit. Yes, we will consider the patient in front of us, but we also have to consider the population as a whole. And this is where it comes down to the difficulty of making really tough triage decisions and allocation decisions, so we'll get into later. Justice. So justice is really how this manifests, is stewarding resources during a time of scarcity, which would promote equity. And all of you are bringing up the question that is true. We have to be really cautious that in whatever protocols we decide to enact in the time of scarcity and in the time of resource dearth, that we don't have a disparate impact on groups that are already vulnerable. And this is where we really have to be really conscientious about how resources are allocated. Next slide, Brad. So some other key principles that don't necessarily fit into the four big ones, but are still principles that we need to consider. Transparency. So, obviously a lot of these guidelines, protocols, policy impact all of us, whether we are medical students or whether we're providers, whether we're your average citizen. So transparency is extremely important. And that also gets into how we choose to challenge or evaluate those protocols and guidelines that are developed. There is also this idea of duty to plan. So this goes back to much of what Dr. Rutherford was teaching you all, is how we need to anticipate a crisis scenario and how we need to try to avoid against this. So for example, UCSF has gone to extreme lengths to figure out how we can get more ventilators should we need more ventilators. So to the situation such that we have the ability to double our capacity should we need it. That is a responsibility. It is our responsibility to ensure that we plan for staffing issues. We we think of scenarios in which we can increase our capacity in order to make sure that we can address a pandemic when we can. Part of the reason why we aren't accepting transfers, part of the reason why we also shut down elective surgeries. Now, it's complicated, right? Because you could also argue there are duty to those patients as well, and that gets into the difficulty of some of these things. But this is all in the context of a public health emergency. So the idea of reciprocity goes into also sometimes called instrumental value. And so this reciprocity is the idea that society supports those who face a disproportionate burden in protecting the public good, and then take steps to minimize that impact as far as possible. So this is like in an influenza pandemic, which that's the closest model. Measures to protect the public good may likely impose a disproportionate burden on healthcare workers, right? And so as a result of that, there is a sense that we need to actually create situations that we minimize workplace risks of transmission, mitigate moral distress, try to prevent isolation from peers and family. All of that is this idea of reciprocity. And that in this particular situation may be unique to the healthcare workforce. And solidarity is this idea that, and SARS really brought this to attention, global attention. It really heightened the global awareness of the interdependency of health systems and the need that there needs to be solidarity across institutional boundaries. So here in San Francisco, how we coordinate efforts across the different hospital systems. More broadly across the state of California, how all the different UC health systems are working together. That's the idea of solidarity. And all that goes into planning, especially in the context of public health. Next slide, Bad. Okay, so I'm not going to, this is again more theory, but it gets more into how we think about broadly when it comes to triage and allocation issues. So there are two different main approaches to how we think about protocols and policies. There's the consequentialist approach, which is the greatest good for the greatest number of people. And then there's the person-centered approach, which is basically all humans are of equal worth, and allocation strategies should emphasize equitable treatment of people as a way of respecting their inherent worth. And really, it's how we balance, while these may seem to be in tension, it's really about balancing both of them, right? So triaging to save the greatest number of lives, which you could say is a consequentialist objective, inevitably depends on some concept of fairness, right? Which is a person-centered objective, in order to decide how you're going to actually figure out who gets supplies and who may not get supplies. But ultimately, it gets back into this idea of how you decide what is the greatest good and how you articulate that in a fair and objective way. Some other approaches that have been articulated, and this is, again, specifically in the context of resource allocation, and I've highlighted a few here. One is the fair innings or life cycle approach. So the idea here is give the resource to those who have not had their fair innings or are not far along enough on the life cycles. This is where age comes in. So perhaps a younger person is more likely to get that scarce resource than someone who has done their fair innings, so to speak. First come, first served is another approach. So whoever gets to the hospital first, that's who's going to get the resource. Now, this is often criticized because it's not always necessary that it's not always clear that the person who gets there first is the most in need, because there might be other factors that go into that. It also may disproportionately benefit those who have the capacity to go somewhere in a way that someone who's perhaps a little bit more disadvantaged may not. So first come, first serve has been vastly criticized. Lottery, purely objective. Draw a name out of a hat, that person gets the resource. Also criticized in the context of, well, is that really thinking about who's going to benefit the most, or how that's actually going to result in the most lives saved or the quality of life saved for the population as a whole. But sometimes lottery does factor into a multi-pronged approach when you think about all the different ways you can talk about allocation. So that's why it's still there, though not necessarily always first on the list if you look at what's written out there. And then there's this idea of social worth. And of course, this is controversial. determining that whoever has the greatest social value is whoever's going to get the greatest resource. And for obvious reasons, no one wants to do this, and nor would anyone say that it's the most ethical way of doing it. However, there is a different concept, and this goes back to the idea of reciprocity. There is a different concept called instrumental value, where there may be a group of people in our population who, in the context of whatever disaster is occurring, serve a purpose or have some value. So healthcare workers, first responders, often in a disaster, may be considered of having instrumental value such that the delivery of resource preferentially to them actually then goes back to serve the general public, because you can preserve that those folks to then give back and offer their value. So that's the concept of instrumental value. All that to say, and this goes to the next slide, Brad. So all of that is a way to think about how we are going to apply these tough principles. And what I'm showing you right now is some of the language that we have used at UCSF to articulate what we believe to be the principles to guide resource allocation and triage for when in times of dire scarcity. Now, I'm going to preface all of this. All of these are things that we think about in the most dire, extreme circumstances, right? This is assuming that we've done everything we possibly can to increase our supply of resources. And for the purposes of discussion, we can think of it, let's just use ventilators as an example, okay? For the purposes of discussion, we have, we have found ways to make a ton more ventilators, pooled all our ventilators in an area, and yet we are still in the circumstance that the demand exceeds the supply. So the principles to think about in allocating resources is the idea that it is determined by the difference that a resource might make on overall predicted survival and quality of life, rather than a first come, first served basis. And these decisions about who gets a ventilator and who does not should be governed by non-biased guidelines, not individual providers at the bedside, right? Individual providers at the bedside, your duty is to the patient in front of you, and it's other entities that can create non-biased guidelines based off universally applied objective criteria, which is the next bullet point, in order to try to be as fair and equitable as possible. Next slide, Brad. So what this means is that there are specific practices that may be ethical in a public health emergency. So for example, visitor restrictions. These are restrictions on, and this is thinking back about all the principles we just talked about. These are things like that are an impedance in individual liberties that may actually be ethical for the sake of the overall public. Visitor restrictions, time trial of ventilator support, withdrawal of ventilatory support from one patient in order to reallocate to another patient, withholding resuscitative measures, delivery of vaccines to healthcare providers. All of these may be ethical. I'm not necessarily advocating for one or the other, but this is to say when it comes to the actual ethical practice in the context of a public health emergency, these are things we all have to consider. Next slide. Okay, so I'm going to give you an example here of what a lot of you may have read about in the press or in New England Journal articles about what a lot of the conversation has been, especially in light of what we've been seeing in Italy and sadly in New York City as well. So in this situation, again, in the dire circumstance that supply and demand do not match up and the demand is much more higher than the supply, various institutions have created protocols to try to be as objective as possible in order to articulate who are the most likely to benefit from something like ventilatory support or critical care resources compared to others. And so this is actually out of the VA hospital system, which actually did a very massive in-depth look at triage protocols in times back in 2010 when there wasn't a pandemic going on right at the same moment. And some of the criteria that they used was actually categorizing patients in terms of these color codes with use of various qualifiers. Now, one is the SOFA score, Sequential Organ Failure Assessment. You may have heard of it for those of you who've been on medicine or done critical care, applying to do critical care. You may have heard of it as well. But this is while imperfect, is one of the more objective predictors. And the next slide, Brad, which includes all these other criteria. Now, the point of this is not for you to know the details of a SOFA score. The point is to know that there may be objective predictors, and even though it's imperfect, that we can use in this context. So go ahead, next slide, Brad. All right, so all of this is to say, and again, I want to reiterate, and this is also echoing some of what Dr. Rutherford was mentioning as well. Luckily, in the Bay Area, or at least in San Francisco, we've instituted efforts to really try to flatten the curve such that we never have to get to this scenario. And we are hopeful that we don't have to. But this is the time where we are planning for that circumstance should it happen. And many of us are on a lot of committees and articulating a lot of different protocols to try to figure out what makes sense for our population in terms of creating objective measures and in terms of creating protocols should we need to allocate critical care resources in particular in the same manner. And that goes across the entire UC system. So I'll stop here and take questions, because I know I just spoke a lot and I want to make sure to leave time for questions.
All right, let's take a couple of questions. If you could follow the chat field, and then I'll just pull up the next stuff.
Yeah, great. So we have a question here. How would you think through the ethics of some New York hospitals that are now not allowing support person for pregnant people during childbirth, regardless of COVID status? So I'm assuming this is in reference to a very similar restriction we have right now, which is that there are no visitors in our hospital, for example. So you could articulate the same thing as even someone who is here for other dire medical circumstance or an emergency similar to active labor are not allowed at the bedside. So, you know, the ethics of this in the context of what happens to those who are not, there are multiple parts of this. What happens to those patients who need medical care, but who are not at all impacted by, or not at all there for a COVID-related response? And then all the support that happens for them. And I think likewise how to think about states using COVID as a pretext to close standalone abortion clinics. Well, I think that's a completely different issue altogether. Clearly not a fair pretext, but again, in the context of COVID, this is a public health emergency. And so what a lot of hospitals are doing is how can we continue to support our patients through these processes, knowing that there are infringements of their care is different from how it would be otherwise. Same thing with those who are undergoing surgery. Same thing with those who are, cancer patients who may need chemotherapy. It's all in the same context. And it does probably feel like it's unfair to them that this is how they have to suffer through this emergency. But alas, it is all in the context of how we support folks through ancillary services in order to get to ensure that they get the care they can receive in that context. How does the capacity for critical care compare between Moffitt and the General? How is the city coordinating a just response with regard to socioeconomic insurance status? So I cannot comment on the capacity of San Francisco General, as I don't have the numbers for you, but I can tell you that the hospitals in the county are all in communication with each other, including I personally have had calls with the ethics folks over at San Francisco General. And this is the responsibility. The one thing we absolutely want to avoid is a patient should not receive disproportionate care if they show up at one hospital and not the other. So just because you show up at the General, you get a ventilator, and you show up at Parnassus, you don't. That is a situation we should not avoid. And Brad may be able to speak more towards the operations about how hospitals are coordinating in order to address that. Several of our pre-readings. Yeah. Oh, sorry.
I'll address the operations in the thread. Maybe answer this question about several of our pre-readings, and then we'll move forward to the last segment.
Sure. Several of our pre-readings laid out the way that socioeconomic status is mediating access to care and resources in the pandemic. Can you speak to additional considerations in applying these ethical principles in a stratified healthcare delivery system? Should we care that the rich have increased access to testing as a form of social value argument? Well, I think this goes back to the justice issue. You don't have to think very hard to realize that there are folks who are not going to get the same access as others. And actually, it's really discouraging. I'm sure many of you have friends in other healthcare systems. Even for us as providers, if we were to get tested, our ability to get tested here is drastically different compared to if you go elsewhere. I have, friends who work up in northern Washington who still have to wait 2 weeks to get a test back, and it completely limits that ability to move forward in a patient's care. So these are our peers, right? Our healthcare practitioners. So you can only imagine the challenge it is if you don't have those resources. So I think ultimately it really shows all the holes in our healthcare system. And in a world in which everyone gets access to everything, this would be a lot easier and probably help us fight this pandemic a lot quicker.
Fantastic. Well, Srisha, thank you so much for your time and expertise here. This has been fantastic. If you could stick around for a couple of minutes and follow the feed, that would be great. Please ask additional questions in the feed and we'll keep an eye on them. And then for the final segment, we have 25 minutes remaining. It's my distinct pleasure to introduce Doctors Sajan Patel as well as Francisco Alvarez. Again, I'll keep the intros brief, but just to say, these are two other faculty members in the Division of Hospital Medicine and two of the first physicians at UCSF to manage patients with coronavirus. I know Francisco has an interest in epidemiology, and thank you for lending your expertise to the thread here. And Saj Patel has become a leading voice internally and externally, and has been recently picked up by news sources for some posting, and one of the early physicians to really encourage the public to adhere to social distancing measures. So thank you both for joining today, and I will turn it over.
Awesome. Thank you. Can everyone hear me okay? Brad, can you hear me?
You're coming through great.
Perfect. So yeah, thanks so much for having us. Real excited to talk to all of you. And just want to I'll keep an eye on the clock to make sure we don't go long. And really the purpose of this is to allow people, I know everyone has a lot of questions, so we really do want to be able to make this as interactive as possible. So we'll leave most of our time for that. And as Brad mentioned, Francisco and I were the first two to take care of patients in the Bay Area. And we'll start sort of by walking you through what went through our head, because we were sort of building our diagnostic schemas and illness scripts on the go, like as people kind of say, like building a plane while flying it. We had no idea what was going on. At the time, there was 7 total patients, hospitalized patients in the entire country, 12 diagnosed total, and we had 2 of them. So we had 30% of all the patients. This was the pre-pandemic phase. And we'd be on CDC calls, for example, with other frontline providers, and there was literally 5, maybe 7 other frontline providers. And now those calls, there's over 100 people calling in, as you can imagine. So it really was kind of a unique, interesting time. And our goal, again, is to make this interactive. And what we'll do at first is sort of, what I'll do is, so Francisco will chat about taking care of these patients once they're admitted, very briefly, less than 5 minutes. I'll quickly talk about what it's like to admit one of these patients. Last week, I did several shifts, what we're calling the Cardinal, where we go to the ER and we admit any respiratory illness patient, because as you can imagine, any respiratory illness patient is COVID until proven otherwise, more or less. And then after that, we will open it up to any questions whatsoever, and I can give some like possible discussion topics. So I think, Brad, if you don't mind, could you quickly pull up, there's a website that I showed everyone if they want to follow along as well. It's infectioncontrol.ucsfmedicalcenter.org. And this is a great website that I use daily to keep up. It's updated frequently. And the first thing that I'll first show is the evaluation guidelines. So if you go down to, so you may have seen this in Natasha's lecture or talk, but basically when I have this in my pocket, printed out, old school. And what I do is when I go down, if they have any of the following, the ED is already evaluating them as what we call an SRIP, suspected respiratory infection patient. And you can sort of see the different things that help with my diagnostic schema. Do they have a fever, cough, my allergies? These are the things I ask the patient, usually over the phone if I can, to minimize exposures. And then looking at different labs, one thing that we're really keying into is this idea of lymphopenia or leukopenia, a low white blood cell count. When often you expect someone to have a leukocytosis in an infection. If their white count is low, that's another point for me to say, hey, is this COVID? Thinking about AST, ALT, COVID tends to can increase AST, ALT, and some other labs that you can see there, including CRP and procalcitonin. And then what we do is we send for the COVID testing. And, hopefully in the near future, we'll have hour or less than an hour turnaround time. So a lot of this, will not be necessary thinking about, we'll still use this, but we won't necessarily need to go down this pathway as much. But in the meantime, while some of our tests take 24 hours or longer, or back when we were first taking care of the patients, we were sending that to the CDC in Atlanta. So there was 3 or 4 day turnaround time. So you can imagine when you have that long of a turnaround time and a lot of other healthcare systems, you have to work with what we know in terms of other sort of labs and imaging. Another interesting thing on imaging, I'd say chest x-ray, oftentimes you see bilateral infiltrates. And that again is another point for me in my head, in my diagnostic schema about is this COVID or not. So I think I'll leave it at there in terms of how I think of a patient when I first hear about them and see them in the ER. The next thing I'll go to, Brad, do you mind pulling up sort of our algorithm? It's the very top link here. And again, I encourage everyone to follow along. This is going to be a very busy algorithm, but this one is so important. And Brad, I don't know if you're able to zoom in on sort of just the top part of that, the initial part. But basically for folks, what this helps us do is realize, okay, if a patient is being considered for COVID, what are the operational pathways that we have to go through? Because as a lot of folks are asking, do we have enough PPE, or how are we conserving PPE? How are we conserving isolation rooms? What is the latest that we are doing? And so this really helps me think about, one, okay, the patient has this, this, and this. The first question they need to ask is, are they getting aerosolizing procedures? And you can see on the left of the screen, that's if they are getting nebulizers, if they are getting high flow nasal cannula. If they're going to be getting anything like that, then we do, at that moment, they should be considered to be on negative isolation, and sometimes we wear an N95. If they're not getting aerosolizing procedures, the current guidelines are a surgical mask is appropriate. So this is really important for me to think about, not only myself, but the folks that will be taking care of them, including nursing, respiratory therapy, anyone going into that room. How do we need to protect ourselves, and what do we need to be thinking about? So again, while you all, I know right now, medical students aren't involved in the care of these, but I would totally familiarize yourselves with these guidelines, with this website, because it'll help you think about how to think about these patients. And this is a great way, a great workflow that I, again, keep in my pocket at all times when I'm admitting these patients. And I think lastly, what I'll talk about just in terms of the clinical management, Brad, if you don't mind, the last resource that I would go to is the one that talks about adult inpatient COVID management working guidelines. This is a fantastic resource that I use, and I have it in front of me actually right now, and I look at it daily. But it kind of tells you the workup, the management, where the evidence is. It doesn't go deep into the evidence, but it certainly goes into what we're doing here at UCSF in terms of things like remdesivir and Plaquenil. And I encourage you again to read this. It's a very quick read. It's done by our local experts here. And so these 3 resources I keep in my pocket at all times to help me figure out how best to sort of triage these patients and then what to do in terms of admission. And with that, I'll let Francisco speak about sort of the management once they're admitted, and then maybe at like 11:46, 11:47, we'll just open it up completely to questions.
Thank you, Sash. Yeah, I'll be very brief just because, a lot of this is changing by the time you guys get on the wards and, are managing these patients. I think a lot of this will change. But just talking about treatment strategies, earlier I saw a question about, is there anything that we're doing besides just, intubating people who need it? And there is a lot that we can do. I'll start off at the beginning, initial patient that's admitted, obviously a lot of this is supportive care, giving them nasal cannula if they need it. You can think about empiric antibiotics. Obviously, empiric antibiotics does nothing for a viral infection, but if and we're seeing low rates of secondary bacterial infection, but it's something that is on the back of our mind as we're evaluating these patients. One thing that's been very interesting about the COVID infection is that patients seem to decompensate in the second week out after they are expressing symptoms, really around like day 9 to 12 after symptom onset. So what we're seeing is, patients will be doing fine, maybe even like looking like they're ready to be discharged. And then, day 9, 10, 11, within a few hours, they go to being intubated very quickly. And so how we can kind of predict who is going to do that is kind of a ongoing clinical issue. Talking about particular, medications and stuff, first thing, oxygen, people tend to be like very flippant about oxygen, but like I always, I remember in med school, they told me like oxygen is a drug. As a physician, you are determining the method of delivery, you're determining the dose. So, nasal cannula up to 6 liters. There's a question about, should we be doing non-invasive positive pressure ventilation? That's like CPAP, BiPAP. They have increased risk of aerosolizing around, so that's controversial. Another option is doing high flow nasal cannula. If you have to go up from there, intubation, and then eventually ECMO. I'll speak briefly about ARDS. ARDS is a huge topic, and this is an ARDS conversation, but these strategies for ARDS is the cornerstone of how we manage these patients that are critically ill. Everyone loves talking about remdesivir and hydroxychloroquine and all these fancy things, but the cornerstone of our management are these strategies that are known in large randomized controlled trials to decrease mortality. These are things like low tidal volume ventilation. So you want to do 6 cc's per kilogram of ideal body weight. If you want to know more about that, I don't know what education you guys have done about ARDS management, but the ARDSNet trial in 2000 decreases mortality. Proning, I won't go into a lot of the specifics, but basically you're improving, you're optimizing ventilation perfusion matching. Seems to be very effective in COVID as well. The initial French study showed it's effective in severe ARDS. Paralysis improves lung compliance. More recent data in ARDS is like plus or minus on paralysis, but it's currently a hot topic as we're talking about needing to split ventilators potentially due to ventilator shortage. And then high PEEP, while keeping plateau pressures less than 30 to avoid barotrauma, you're decreasing atelectasis and you're improving oxygenation. And then lastly, obviously like, inhaled prostacyclins or inhaled nitrous oxide like Lipros to further optimize ventilation perfusion. In my last few minutes, I'm just going to talk quickly about pharmacotherapies, obviously very hot topic. Remdesivir, there's currently 2 clinical trials ongoing, one at the NIH that's remdesivir versus placebo, and then one at Gilead that's high dose remdesivir versus low dose remdesivir. Anecdotally, seems to be much more effective than a lot of us even expected with clinical improvement in less than 72 hours. Obviously, it's not a silver bullet. Some patients will die despite getting remdesivir, but seems to be, potentially having a mortality effect, but we'll see what the studies actually show. Right now at UCSF, we're trying to enroll everyone in the ICU or anyone who's hospitalized with moderate to severe disease in a remdesivir trial. Then there's a question about hydroxychloroquine plus or minus azithromycin. Obviously, it has been in the news a lot recently. The data for that is really bad. All of this comes from a paper that looked at 20 patients, so very low end, and their primary outcome was decreased RNA, like increased cycle times, which might not be clinically meaningful outcome at all. In fact, one patient in the hydroxychloroquine arm died versus 0 in the standard care arm. There's currently ongoing studies for post-exposure prophylaxis, prevention in healthcare workers, and just using it as standard treatment. Obviously still very controversial. At UCSF, we're considering this for hospitalized patients who are not eligible for remdesivir due to various ineligibility criteria. And then I think the last one that has really gotten a lot of news is lopinavir, ritonavir, which are protease inhibitors that are used in HIV. Notably, there was a recent New England Journal study that showed no effect either on mortality or on clinical improvement. This is based off 200 patients, so I think a lot of us are kind of moving away from using Kaletra. And then the last thing I'll say is steroids. The use of empiric steroids in ARDS is very controversial. A pulmonologist will talk off your ear about the data for and against it. Definitely in COVID, we are saying to avoid steroids based off data in SARS and MERS that showed increased viral shedding and worse clinical outcomes with patients who receive steroids. So try to not use steroids unless you need to for another, whether they have other comorbidities that might require us to give them stress dose steroids or other things. With that, I think I'm going to open it to questions if anyone has anything that we can take.
And yeah, and maybe I'll just sort of make it clear that you can ask us anything here. I think Brad really wanted us to be able to do a wide-ranging topic. Something that's been big in the news, as people have seen, is sort of the emotional and psychological impact taking care of patients. I think Francisco and I had very different reactions and emotional takes on taking care of these patients. We can talk about, I see some questions here about UCSF operations. So I'll, actually Brad said that. So we're happy to answer that. And then what you can do as a medical student, we can talk about that. Also what it's like for a post to go viral on social media. So yeah, so the first question is, who is eligible for tests? Does that sound okay, Brad, to just open it up?
Yeah, sounds good. I'm happy to weigh in on any of the operations if I can help.
So who is eligible for testing right now at UCSF? Are we over capacity still for testing at UCSF Bay Area? Right now, eligible for testing at UCSF, if you, my assumption right now is, in the ER, if you've seen, they have tents outside where we're sort of fast tracking people and testing if necessary. I think if you are pretty ill with symptoms that are consistent with COVID, then they can test you, especially if you're going to be admitted. I will say though, if you call your doctor and you say that, I have these symptoms, I'm feeling okay though, I don't need to be in the hospital. A lot of times they'll say, right now we're going to assume you have it, just stay at home and quarantine. Healthcare workers, if you do fall ill with this, then you'll call occupational health and they will very likely test you because they don't want you coming to the hospital if you're positive. Are we over capacity? Oh, sorry, go ahead, Brett.
Actually, can I add to that as well for the testing? And Sudge is right. These are all high priority testing. Right now, just about everyone's eligible for testing. A lot of the triage decision making is where is the testing being sent? And patients who are sort of quote unquote low priority are patients who are well going to the outpatient community. Their testing is being sent to, for example, Quest or DPH or outside labs where there's a longer turnaround time. UCSF is prioritizing in-house testing really for folks who are either being admitted to the hospital because their hospital stay will be impacted by their testing results, or people who are being discharged to high-risk settings in the community, for example, folks in shelters, communal settings, or folks going to SNF. And so we had very limited testing as of last week. Over the weekend, we got about 4,000 test kits of swabs, actually, from the federal government. And BioHub has gone online. And right now, they can do upwards of 400 to 500 tests a day, ramping up to maybe even 1,000.
And maybe real quick, I'll show you guys the dashboard we're working on right now. I know this is low tech, but you can see how much testing we've done. Is it backwards on your screen or forward? I don't know.
That's good.
Oh, perfect. So this is the dashboard that's sort of currently in operation, sort of in a draft phase, but it shows the testing we've done. I think we're in the thousands now. So it's pretty neat. This is how we track how much testing we're doing, turnaround time, patients we have. Just so folks know, we have 10 folks, I think, in the hospital now that's COVID positive, 19 total, 9 discharged, 2 in the ICU. So maybe I'm really, when we spoke earlier about possibly that we have flattened the curve, I'm super optimistic and hopeful, but I don't want to take that for granted. I will answer one more question, then I'll open up to other folks to answer it. I'll answer Rachel's. I see Mary's. I'll let someone else take that. Allison and Alexander, I'll let someone else take those two as well. But Rachel's question, I think, is an important one. And I'm very comfortable sharing this. Are you feeling scared for your own personal health and safety? So yes, I think that I think there's a lot of angst and anxiety about this. When I originally, I posted something about this, about the fact that there's a chance that I'll get this. I still think that's true, but I will say the more reading I've done about it, I do, trust that we are using appropriate PPE, and the reading that I've seen on this so far is that our chance of getting it with really good hand hygiene, with really good PPE practices, and PPE again is personal protective equipment, seems to be pretty low. That being said, we are exposing ourselves often to it, so it does increase, the exposure time does increase. To add to that, I think what we've experienced, there's such a variety of emotions. I think anxiety, some guilt about when I first took care of them, am I going to bring this home? How do I mitigate that? My dad was visiting that weekend, and he's over 60, so didn't want to. I can imagine if I brought that home with him. I had a wedding to go to the other weekend of a best friend that I decided not to go to. And I think that these are all the things that everyone taking care of these patients, it's a challenge that we're all facing. Some ways that I think about how to mitigate this, one is, I wear a different set of clothes to the hospital, and then I change into hospital scrubs. As Brad alluded to, we have a respiratory isolation unit where when you go in, you change into a different set of scrubs from your street clothes. You take care of the patients. When you leave, you shower, and then you take out from there, and then take off from there. So you mitigate that risk. But yeah, there's other things that people talk about. I mean, one, getting it personally and how to sort of cope with that. And then two, this idea of this pariah effect of getting worried that, other folks, how they're looking at you. When I was first taking care of the patients, I certainly felt like people kept their distance. And I honestly, that's what everyone's doing now, and that's appropriate. But at the time it was pretty hard to cope with, but I felt more at ease and accepting of that, and it's probably the right thing. But I want to just say out there, as Brad mentioned earlier, everyone's going to have a spectrum of reactions, emotions of dealing with this, and we're doing our best to reach out. And I personally would want to be a resource for anyone taking care of these patients of sort of the journey I've gone through, as well as Francisco.
Yeah, and I'll also echo there was an excellent piece in the New Yorker by Togwande about healthcare worker exposure and stuff. I'd say, I personally, I think it's important to take the appropriate steps. I'm not currently overly worried beyond what I think is like an appropriate level of worry about my own personal health and safety. But it's certainly something that's varied between different providers, different healthcare workers, in terms of the level of anxiety they have about it. And I think that's completely justified. I want to talk briefly about Balai's question here, about medical students being part of the essential parts of the healthcare team and going on rotations, but then feeling nervous about taking up, resources like PPE and things. And I think that's actually something that's really important, and that's something that I would love to hear your guys' responses. I guess not right now, we're kind of short on time, but I think that's an evolving question, because one topic of conversation among my colleagues has been, in Europe, they're using, especially in Italy, they're using medical students quite heavily, and like even fast tracking like later year medical students going directly into like being primary providers. Luckily right now in the United States, at least outside of New York, we're not quite in that kind of personnel crunch. And then the other thing to think about is where our, culturally, where our responsibilities lie, where we do feel, on the one hand, yes, you're, as medical students, you're part of the healthcare team, but we also feel a responsibility to kind of protect you guys, if possible, from, unnecessary exposure, and how to balance that. I think it's going to be an evolving question. This is, we're kind of, this is the largest pandemic that we've had since 1918, pretty much. So, I think it's going to be an evolving situation in terms of how do we think about using these parts of the care team.
And I can add to that as well, because thank you so much. And it also says being on the wards, and I would separate being on the wards and using PPE, because there are evolving PPE use guidelines where we are having, so even if you show up to the wards doesn't mean you're going to be using PPE necessarily. And so for folks that need PPE, for example, C. diff or other infections, we are coming up with some stringent guidelines that one person enter the room. And so I think there are still ways to be participatory, to show up to the rotation, to learn, to engage. And we have the same questions for residents on the team. And so we're really trying to implement strategies to minimize PPE use. So I would disentangle those two things, because for those of you on rotation, I think that there can still be a lot to be gained. And I think that our country handled this pandemic in an awful way from the very highest level. And I'm much more hopeful for your generation that we will handle this better. There's 3 minutes. I can tackle some of these operational questions. Francisco and Saj, feel free to chime in. There's a question about how the city is coordinating care across hospitals. There are daily calls happening with CEOs across hospitals, looking at where the resources are and where there's beds available. I can't speak as much to the county and DPH, but I know that, for example, we are having a phone call with Dignity Health leaders. They have empty units at St. Mary's, and they have empty units at St. Francis, where we are talking about expanding capacity there. And I mentioned earlier that we are also opening up our own unit at potentially at Mount Zion, should we come to that situation. What COVID clinical trials are ongoing or planned at UCSF? I'm not aware right now of other trials. There are over 100 on clinicaltrials.gov. I did get a solicitation about post-exposure prophylaxis for frontline providers. I don't know that we are officially a leading site for that, but I know there is some interest in studying the use of agents for post-exposure prophylaxis for people who have been involved. And there's other studies looking at temperature monitoring beyond therapeutics. Evidence for inhaled versus systemic agonists. We have not given tocilizumab here. I know that it has been, IL-6 agents have been of interest, but we have not done that. And really the corticosteroids, as Saj mentioned earlier, there's a recommendation against using those. But I know there has been some limited use in China, especially for some of the sicker patients as well. Beta-2 agonists, I'm not aware of studies looking at inhaled beta-2 agonists. We use it for wheezing. The one point that I'll make is that we are trying to avoid nebulized medications, and so trying to use NDI when possible because of the possibility of aerosol generating procedures. In the case of a pandemic, how do you find the right balance between practicing EVM versus relying on anecdotal experiences? And I see we're at 12 right now. We might try to respond to some of these via the feed. This is a tough one, and those of you who listen to Grand Rounds might have heard Sarah Dornberg and Matt Aldrich say we have to be careful. Saj and Francisco have been on these CDC calls where a lot of anecdotal evidence is surfacing, and so I think we need to, if we're going to be using therapies, we should be using them in a clinical trial type scenario. And thank you. I see Saj is responding for that.
And I'll just add in briefly, outside of the pandemic scenario, as you go into your clinical practice, whatever your field will be, you'll see that you're very often, much more than you maybe even imagine as a medical student, in gray areas, like what we call like evidence gray areas, where we have a little bit of data, but we don't really have a great information. That's where a lot of like expert opinion comes in. And so I think part of navigating that balance between evidence-based medicine and your own clinical experience is just part of being a physician. That's part of kind of the art and science of medicine.
Great, and I'll take Derek's and Jacqueline's questions and then conclude. I want a second chance at that. It's a 1 minute video, so I want a second chance at that. Derek said, I've heard Harvard hospitals are requiring all healthcare providers to wear masks. Yeah, so Atul Gawande wrote this article about universal masking. It's controversial. Even Partners Health said there's not evidence to show that this is going to have a significant impact, but this has been used in certain countries. UCSF is going to allow providers to do this in certain circumstances, especially when we are not able to practice social distancing and folks are working very close together, and there's some desire to use this to prevent healthcare associated transmission. But there's not really evidence to support universal masking. But you will see probably more of this picking up. It's a careful balance between keeping providers safe, patients safe, and also resource allocation and utilization where we have a shortage of masks. To Jacqueline's question, how will this impact teaching on the wards as time allotted for feedback? Funny enough, as of now, the teaching service is actually pretty quiet. We had the first day ever at Moffitt where a long call team did not have any admissions. Currently, our faculty only services are managing these patients primarily for PPE conservation. And also we've been devising new systems of care. And so right now there's a lot of time on the teaching service that may change over time. And I think if people are overwhelmed with work, sadly, I do think teaching is one of those things that falls off, but teaching with quotes, I think there's still a ton of education to be gleaned from being on the wards and engaged in care. So with that said, I want to thank Drs. Saj Patel and Francisco Alvarez. And if you'll bear with me, I see our numbers are declining. I'd love to conclude. As I mentioned, this was a video that my friend Zach took. And thank you for those of you who have showed me I can share computer sound. And I'm going to do that right now. Let's see. And tell me, is the sound working? Is this working?
No.
Sorry, Brad,
Not on here, I
no.
Let me try this one more time. Give me one more. Give me one more chance here. I hit the button that says share. Let me see. And if not, I'll give up. All right, it's not going to work. Well, I will make this link available to the class. It's a beautiful video of neighbors singing "Lean on Me" together spontaneously during their social distancing practices. Thank you all so much. Oh, my earbuds. All right, I'll try this one more time without my earbuds. So I'll turn off Bluetooth, and if this doesn't work, I will abort mission. This brought tears to my eyes, so let's see if this. I will share the link with you broadly. Thank you all for joining today. To all of our presenters. Oh, it was working. All right. I can't hear it, but I will do it. I will play it and when this video ends, the conference is over. Thank you all so much for joining, and please feel free to keep questions going on the on Ilios, and we will address those. And I appreciate everyone.